welcome to this year's annual research day. And I was going to go through an acknowledgement of the fact that where we're here, but also our department is located within the unceded and traditional territories of more than 250 First Nations and Indigenous peoples. And I will take you briefly through the agenda. So a few housekeeping issues for me. Then we will have the State of the Department address by Dr. Yatham, followed by our plenary lecture by Dr. Agarwal. Then we will have an extended coffee break to allow you to interact with our speaker, but also to spend some time viewing the posters. That will be followed by our first set of lightning talks. And again, rather kind of, and after the lightning talks, we have a lunch break. And then we will have our faculty lectures by Dr. Menon and Dr. Azar. Then we will have our award presentations. And what is new for this annual meeting is we also have immediately after the end of the academic part of the meeting, there is a meet and greet for people that want to hang around and meet with other members of the faculty, particularly useful, I think, for trainees that are looking for mentors or opportunity to collaborate and work more closely with other members within the department. So the posters are outside, but we also have posters in our e-gallery. And you can use this particular QR code to access from your phones to access the e-gallery directly. And of course, the e-poster gallery can also be accessed through our departmental website, and it will stay on for some time after the end of this of today. Finally, as every year, we vote for the best lightning talk, and we also vote for the best poster. And we have both the QR code and also the links to facilitate voting. And something that is going to be different this year is that there is a request from us that to make sure that we are not biasing the results of this vote and that each poster and each presentation is judged upon their merit, we will request that people do not vote for members of their immediate departments. So, or the immediate departments, immediate collaborative groups or labs. So we're not going to police that strictly. We trust you to be honorable in this respect, but it would be nice that we can get a little bit of a better spread that reflects the genuine value of the different talks. And with this, I would like to invite Dr. Yadam to give us the State of the Department address.
Great, thanks, Leah. Good morning. Gives me great pleasure to welcome you all to the annual Department of Psychiatry Research Day. And as Sophia acknowledged, we're hosting this event from the traditional ancestral territories of Musqueam, Squamish, and Tsleil-Waututh First Nations people. And we're also aware some of you are joining us from our distributed sites, which are located on unceded territories of Sykes, Okanagan, Leyton, and Lekwungen people. And we're, of course, grateful for the opportunity to work and live on these lands. The objective of the Research Day, of course, is to showcase and disseminate some of the research that's being conducted in the department to advance knowledge and translate that knowledge to improve patient outcomes. And of course, you can't do research without research funding. And this slide shows you the amount of funding that the department has attracted during the last fiscal year. It's about $11 million, which is a bit less than the previous year. But that's sort of within the average range for the department. And that funding is the peer-reviewed funding. Of course, we also attract a very large amount of philanthropic funding, which is not included in that figure. And all of this funding, of course, supports research that's being conducted in the department, but also that funding, including philanthropic funding, supports a number of other activities of the department. And one of them, of course, is recruitment of world-class faculty members. And this slide provides details of some of the people that we recruited within the last 12 months. So we have Cam Karamatian, who was recruited as the Canada Research Chair Tier 2 in the early intervention area. Tammy Vanderwall has been recruited to research on youth depression using imaging strategies. And then we have a new faculty member that's going to be joining to one of our distributed sites, the Northern Health in Prince George, Dr. Sinan Gloxas, who is a world-class researcher with the expertise in epigenetics, early intervention, psychosis, and he's currently working in Amsterdam and had previously worked at Yale. And we're just waiting for his immigration to be completed so that he could start working at the Northern Health program. And that will hopefully happen within the next 2 to 3 months. We also have a number of other positions that we are recruiting for. One of them is a position in concurrent disorders. That's actually been completed. So one of our own who was trained in our program is the successful candidate for that position. The announcement hasn't gone out, but I can say that it's Dr. Puya Azar is the successful candidate. So the announcement should be going out within the next couple of days, I think. And so he's going to be starting as an assistant professor in the area of concurrent disorders to be based at the Vancouver General Hospital, and his position will start as of July 1st. We're also in the final stages of completing recruitment for a faculty position in data science. I think most of you will have attended the presentations by the 3 candidates that were interviewed for that position. Incredibly talented. We had 35 applicants, and the committee spent an enormous amount of time trying to narrow that down to 3 candidates. And I think they may have just met yesterday. I haven't received the recommendations yet. So that position will be finalized fairly soon, I think. And as you might have been aware, we had articulated in our strategic plan, our goal was to ensure that we have at least 1 academic faculty position at each of our distributed sites. So we have the funding for those. And so the adverse for the positions at Island Health and also Fraser Health are currently running. So we are looking for people for those positions. So if you know anyone who might be suitable for either of those positions, please encourage them to apply. We submitted 3 applications for the Canada Research Chair calls to the Faculty of Medicine. We haven't heard back as yet, but hoping to hear sometime in July. So lots of activities happening within the department. The philanthropic funding also supports a number of other initiatives. One of them, of course, is the Marshall Fellows Program, which has been running in the department for almost now 7 years, I would say. And this program funds between 4 to 6 fellows every year, supporting training of next generation of researchers. The successful candidates for this year haven't been announced, selected, and that announcement should be going out within the next couple of days. When we developed our strategic plan, one of the things that we heard from our clinical faculty was that they wanted opportunities to have some funding to do research. And so as a part of that, the department has initiated a stimulus grants program led by Sophia, and every year that program funds clinical faculty and junior faculty, including residents. And this year we had 3 successful candidates who were announced early this year, and applications for the program for next year are just opened recently. The other thing that we said that we would do was to implement master's program in translational psychiatry. And this has been in works for quite a long period of time, initially started by Lynn Raymond, and then subsequently when she stepped down from her role as the associate head, Ray Lamb took over, and that process has now been completed. The program is up and running, and the good news is that we actually had 2 fellows that have been accepted into that program. So those are the 2 inaugural fellows that are going to be going through this program. Very interesting. The goal, of course, is to train the next generation of scientists to pursue research in psychiatry. I understand that a lot of people, I don't know how many are here today, but my understanding is that we actually had a lot of people registered to attend the research day today. So some of them may be joining through online. And I think that probably shows some of the interest in the research that's being done in the department. Now, there will be opportunities to prioritize where we want to go from here. Most of you are aware we had an internal review of the department a couple of years ago, and they came up with some recommendations, and some of them have already been implemented. But also, we won't have an external review of the department early next year, which when we heard about it, I was a bit surprised because we just had a review a couple of years ago. And the reason is that apparently every department within the Faculty of Medicine goes through an external review at every 10 years. So the last review of the department, the external review, happened in 2016. So we are due for 2026. So that's why the external review is happening, because it's a 10-year kind of cycle. So that'll happen in January, and we're expecting some recommendations from that review. So as we embark on the strategic plan refresh, we're hoping that review and also the consultations will inform in terms of the strategic direction for the department for the future. So I do encourage all of you to participate in that external review as well. So with that, I will say that just looking at the program for the day looks fantastic. Lots of cutting edge research that's going to be presented. So enjoy the day, and I look forward to seeing and connecting with all of you during the course of the day. Thanks very much.
So it is really a pleasure to introduce our keynote speaker for today. This is Dr. Mahavir Agarwal from the University of Toronto. He's the medical lead for clinical research in the division of schizophrenia in CAMH, but despite his relatively young age, he's one of the international leaders in the field of metabolic psychiatry. As you know, this is an emerging field within psychiatry that puts a lot of emphasis on both peripheral but also central metabolic dysregulation across a number of psychiatric disorders. But he and his group in Toronto have really pioneered the study of metabolic dysregulation in terms of insulin signaling and the potential interventions that could be therapeutic and helpful. So we're really thrilled that he's here to share with us these unique and very novel insights.
Thank you, Sophia. Thank you for having me here. You are incredibly lucky to be working at such a beautiful campus. And thank you for the wonderful tour of the campus last evening. We are going to, over the next 45 minutes or so, assess metabolic health and mental illness from various angles and see what we can do about it and whether solving these problems helps us solve more problems than one. And so if we can dovetail it with some of the other unmet needs. These are my disclosures. I've worked with HLS Therapeutics that provides clozapine in our system, and Boehringer Ingelheim as they were developing their pro-cognitive molecule, which ultimately did not pass phase 3. So these are the objectives today. We are going to briefly review the etiology and pathophysiology of metabolic dysfunction, and then we'll review what we know as of now, so currently available treatments, and then we'll see how we can take this knowledge and build the next set of interventions or understanding, and where do we go from there. All right, let's start with the first one. And let's start with the why. So the gentleman on the left of your screen is well-known, Albert Einstein. The one on the right is less well-known. That's his second son. His name is Edward Einstein. He wanted to be a psychiatrist and was in a medical school when he was diagnosed with schizophrenia. He was treated with antipsychotics and ECTs, similar to what one would expect today, and then died at the age of 55 from a stroke. His father, of course, lived to 75, 76 years of age. And this anecdotally represents the 2 decades of life that we now know as an established fact in our field. Our patients tend to live less than the general population. Advances in cardiovascular health management that have benefited the general population have not really filtered down to our subset, the population we treat. And this overlap between metabolic and mental health is by no means new. As early as the 17th and the 18th century, this overlap between diabetes and mental health was recognized, although in less politically correct language. And so we know that there's this background that these two groups of disorders share. This was shown even more sort of emphatically in a landmark publication by Ben Perry in 2021, and they have an updated paper in 2024, where they talk about this bidirectionality, looking at about 10,500 people from the Avon longitudinal study. And what they found was elevated insulin levels during adolescence, so again, a marker of poor metabolic health, predicted the development of psychosis, and elevated BMI predicted the development of mood disorders. In the updated paper, they have also been able to look at inflammation measures, and it appears that pro-inflammatory states, as well as a poor metabolic health, contributes to poor mental health when in the adulthood. And then this is another highly cited paper from 2023, where these authors try to look at effect size variations across various body systems, across multiple psychiatric disorders. And what's startling about these graphs is that the highest effect size changes seem to happen in the metabolic space. There are, of course, caveats to this finding, and the blood glucose can move more than brain morphometry can. So there's an inbuilt control there. But the fact is that this shows that metabolic health is prevalent and important in each of the major psychiatric disorders that we deal with in our day-to-day clinical practice. And the factors that associate SMI, severe mental illness, with obesity and diabetes are not linear or one. They are confluence of at least 4 separate groups of factors. There are, of course, lifestyle factors. Our patients, for a variety of reasons, don't have access to the best lifestyle. But there are also inherent biological factors. Levels of proteomic and genomic studies have shown overlap between diabetes and severe mental illness. There are, of course, system factors. Our patients may not have access to GPs. And then there are treatments. And of those treatments, antipsychotics seem to be the worst offenders. And if you look at antipsychotics, their use is not restricted to schizophrenia or severe mental illness narrowly defined. It's growing quite widely and steeply. So from the last data we have, there was a 100% increase in the use of antipsychotics among children in a 5-year time span, which is startling. And then this also then translates to higher use in populations such as autism and intellectual disability. And if you look at those populations, their lifetime accumulation of metabolic risk sometimes outpaces schizophrenia because of how early they are started on these drugs and how long they have to be on it. This is sort of the typical graph figure that we have of the weight gain liability of metabolic agents. You have the clozapine and the olanzapine as the worst offenders when it comes to antipsychotics, and drugs like aripiprazole and ziprasidone are supposedly weight neutral. You have a similar, although at a lower level, spectrum on the level of antidepressants as well. But then what more research has shown, and more recently work has shown, is that these differences are true when you look at stable, chronically treated population. When you look at more younger people or people who are not exposed to antipsychotics, these differences become much more muted. So these are landmark data, again, from Christophe Correl's group in 2009, just published in JAMA. So the graph on the left of your screen is what we typically would expect. Olanzapine causes a 7-kilogram weight increase, whereas an aripiprazole causes less than 2. However, if you were to look at just the antipsychotic naive young group, the differences are much less. An aripiprazole can cause a 4-kilogram weight gain, whereas olanzapine, so the difference is twofold rather than fourfold. And we see that in our metabolic clinic every day as well. Our system has moved to starting aripiprazole and risperidone or paliperidone as their first-line antipsychotic. But that has not translated to less metabolic liability. We still have lots of people gaining lots of weight on drugs like aripiprazole. And so the message is that when you're looking at young people, antipsychotics can do a lot of damage and a lot of early damage, and therefore we must be on our guard. And then these are data that came out of Denmark at a population level study a few years ago now, which showed something even more startling. So they were able to look at the rates of diabetes across lifespan among the normal population, people with schizophrenia who were not on antipsychotics, and then people with schizophrenia on antipsychotics. And they found that people with schizophrenia have a 3 times higher risk of developing diabetes just off the bat, speaking to the genetic overlap. And then if they were on an antipsychotic, they were 3 times more likely to develop diabetes on top of the 3-time risk imposed by schizophrenia. The key takeaway for me in that paper was that if you look at the purple bar on top, that is any antipsychotic. So that includes first generation and second generation antipsychotics. And across the board, antipsychotics seem to increase the risk by 3 times, and there's no significant difference between an olanzapine or an aripiprazole or a ziprasidone or a given first generation agent. Which again makes you wonder, what are the mechanisms that are driving this, and might these drugs be more similar than not? And these are some of the questions that our lab has focused on lately, and I'll talk to you about that in a bit. And then there are implications about beyond cardiovascular morbidity as well, because we know now in very real, measurable, demonstrated terms that antipsychotic-induced weight gain is the number one reason why people go off their antipsychotics. And once somebody's off their antipsychotics, you can imagine that the overall outcomes become worse than they would have been if they stayed on treatment. And this eventually leads to higher social care costs. As I was starting my postdoc, this paper came out, which was very interesting to me because they were able to show the cost of metabolic dysfunction on cognition. So we know that patients with schizophrenia are already 1 to 2 standard deviation below normal. This paper showed that presence of metabolic dysfunction adds a 0.3 cost on top of that. And then we were able to extend some of this work to mood disorders. I'm sorry for the small print, but essentially it also shows that within mood disorders, across mood disorders, and across types of metabolic dysfunction, there is about a 0.35 cost to cognition when metabolic problems are added on. Which then makes you wonder, if you took it away, what would happen? Would cognition improve? That's something that we have not been able to solve in severe mental illness. And does that provide you then an opportunity not only to improve metabolic health, but also possibly cognitive health? And then as a field, we are not doing very well when it comes to managing this. Again, I keep going to Christoph Corell's group because he has sort of laid the groundwork for this in his decades of work. And so these are landmark data, again, from 34 community sites in the US. The average age of this sample is 20 years. The average duration of exposure to antipsychotics is 3 months. The cutoff was 6 months. And already you see that more than half have developed dyslipidemia, about 15% have prediabetes. So in such a young, early population, we already have significant metabolic dysfunction. And if you look at the light bars, which are the rates of intervention, they are uniformly 0 across the board. And so as a field, it is likely a training issue. It's also likely an issue that we didn't have good interventions, or we didn't have good evidence around interventions, that our field has not really focused on treating metabolic health as its own problem. We have tried to hive it off to other groups of practitioners, and that hasn't worked well for our patients. And so to summarize the first objective, the cornerstone of our management strategy as it applies to severe mental illness, it's very effective. Please don't go back from this presentation thinking I don't support the use of antipsychotics. I prescribe antipsychotics every clinical day. Antipsychotics are one of the most effective treatments we have across medicine, with a number needed to treat of about 2 to 4, depending on context, which is phenomenal. However, they do also add to the metabolic burden of the illness, which adds to the burden of the illness overall as experienced by our patients. And therefore, we need newer targets and strategies. So the idea here is to say that you had a world one where there were no antipsychotics and our patients would die at maybe 40 years of age on average. And then you have a world where you have antipsychotics and therefore there is a 20-year increase in lifespan, let's say. But we haven't reached a place where we could have a lifespan of 80 years, which is where our general population is. And I think if we addressed metabolic dysfunction, we could get to world 3, where we have all the benefits of the antipsychotics as they are, but none of the downsides. That's the sort of theoretical argument. All right, so let's review the currently available treatments and the evidence behind them. So when faced with metabolic dysfunction, these are largely the options that you have. You could reduce the dose of the antipsychotic, the offending agent. You could switch the antipsychotic for another agent with less metabolic dysfunction. You could try non-pharmacological interventions, such as diet and exercise. And then there are add-on pharmacological interventions, such as the metformin, topiramate, and GLP-1 receptor agonists that we'll speak about. In general, the evidence for dose reduction is pretty thin. The plateauing, the dose response curve is rather flat. And so there's a plateauing of metabolic risk once you reach a therapeutic dose. And so at that point, if you want to reduce weight by reducing the dose, you will likely fall below the therapeutic dose and therefore increase risk of relapse. So not a great idea overall. Switching can work in limited contexts. If somebody is on a high liability agent and you're going to take them to a relatively low liability agent, that might work. But then there is the inherent risk of the switch. So depending on the clinical situation, a switch may be reasonable sometimes. When it comes to behavioral interventions, so this includes diet, exercise, CBT, the evidence is not great up until now. So this is a meta-analysis that came out in 2017, which shows that over 6 months or 6 to 12 months, it is significantly better, but the better is only by 0.2 kilograms, which then makes you wonder the cost effectiveness of this intervention. And so this was expressly studied in this paper that came out in 2018 by Richard Hall's group, which was the largest study ever done looking at behavioral interventions with more than 400 patients. And they followed a 12-month sort of timeline with structured group intervention. And they found that at the end of the study, neither was it clinically effective nor cost effective. Again, sort of makes you question whether behavioral strategies by themselves are useful. Again, please don't think that I'm saying behavioral strategies should not be used. Diet and exercise form the base block or building block of every healthy life. What I'm trying to say is that they may not be enough. And so just telling somebody to run more or eat less is not going to be helpful in the context of antipsychotic-induced weight gain. And so then we come to pharmacological approaches. So we have done a network meta-analysis looking at all the evidence till date. And in our efforts, these 3 agents come to the top: metformin, topiramate, and GLP-1 receptor agonists. In terms of pure effect size, GLP-1 receptor agonists seem to be higher. And these are pre-semaglutide data. So once semaglutide is in the picture, we still are yet to get randomized control trial data, but looks like the effect size is going to be larger. Metformin and topiramate are reasonable choices. Metformin, the effect size is 3.5 kilogram, but I think we need to delve deeper into it to understand how that 3.5 kilogram came about, because there are interesting nuances in how metformin works. If metformin is started for first episode individuals, the effect size seems to be double the effect size if it's started in chronic individuals. And so what you want to do ideally is to start metformin at the earliest possible opportunity, because the maximum bang for buck happens sooner. We have also shown that metformin works for antipsychotic-induced dyslipidemia as well, which is pretty useful. Antipsychotic-induced dyslipidemia tends to be hypertriglyceridemia, not typically LDL. And so statins are not indicated. Anyway, these patients are so young that they wouldn't register on the Framingham risk score. And statins are not appropriate. Metformin lets you do 2 things at once. If started soon enough, it prevents weight gain or treats weight gain, and it also helps with dyslipidemia. And then we were also able to show that if you started metformin right at the same time as you were starting antipsychotics, so primary prevention. So these are studies that have been done across the world. 4 of the trials started antipsychotic and metformin together. And a meta-analysis suggests that within 12 to 16 weeks, there's already a 4 kilogram difference in people who are started on metformin versus people who are not. None of these studies included individuals on clozapine. And because clozapine is one of the biggest inducers of weight gain, we wanted to test that out in our data. And so I have access to the clozapine clinic and the metabolic clinic at CAMH. And so we were able to look at those data. So these are Nicolette and Kate. Nicolette is a postdoc. Kate will graduate in 2 weeks, hopefully. And so these are 400 charts of people who were started on clozapine. About 70 of them were started on clozapine and metformin together. When I say together, it means within a 3-month time frame of when clozapine was started. And we see that individuals on clozapine and metformin together did not gain weight on average at the end of 1 year, whereas the group that was on clozapine alone steadily gained weight as expected and gained about 5 kilograms at the end of 1 year. And this was not restricted to weight alone. We had a similar effect showing on fasting glucose and triglycerides as well. Again, sort of in the retrospective clinical data, proving that metformin can be an effective preventative agent. But the thing that impressed me most was this graph. We know that clozapine is a difficult drug to take. Half of people who are started on clozapine will stop it at the end of 1 year. We were able to show that people who were on clozapine and metformin together, they were 15% more likely. I mean, the compliance rate was 15% higher in that group compared to those on clozapine alone. And so when you think about the evidence that weight gain is the most important reason why people stop their antipsychotic, then it would make sense that if you took care of it, they should stay on the drug longer. And this shows that it actually works. And so if you did take care of metabolic health better, perhaps our patients would have an easier time staying on their antipsychotics. And then in my postdoc, we also did the opposite study. So we sort of asked what happens when you do the status quo, which is if you allow the GP to intervene when they feel comfortable intervening, they will likely start metformin when somebody has developed prediabetes or diabetes. And so we had this cohort of people where they were young, they were started on antipsychotics, and then they were started on metformin once they had developed prediabetes or diabetes. And then we found, so this graph shows HOMA-IR on the y-axis, which is an index of insulin resistance. We found in our trial that metformin does bring insulin resistance down. However, it had no effect on weight if you waited long enough that somebody developed prediabetes or diabetes. Metformin is not a weight loss agent in the general population or in the diabetes population. So to review the whole metformin story, it can prevent antipsychotic-induced weight gain. It can help with dyslipidemia. It has an effect size that is double the effects early on than it is later on. And then once somebody develops prediabetes or diabetes, the entire weight loss efficacy goes away. And so all of this taken together suggests to me that metformin is a highly effective preventative agent. It does not do so well when you're looking at treatment. So if somebody has already gained weight, you have missed the boat in terms of intervention, then metformin may not be the best option. And therefore, that's sort of the need of our field. What happens when we have not intervened early, or if metformin hasn't worked, because it will not work for anyone. No drug works for everyone. And that's where I think the opportunity of the GLP-1 receptor agonist comes. GLP-1 receptor agonists, in terms of sort of the history or the background biology, the analog comes from Gila monster. They eat once or twice a year. And so scientists started looking at the reason why that might be the case, and they came across GLP-1 receptor agonists. University of Toronto has done a lot of pioneering work here. Dan Drucker is at University of Toronto. He is one of the big names in GLP-1 receptor agonists. The wonderful thing about these drugs, aside from all the media attention they have gotten, is that they seem to do everything everywhere. Their major effects are, of course, they have a glucose-dependent insulin secretion, which is great because then they don't cause hypoglycemia. They also cause delayed gastric emptying and a sense of satiety that seems to be quite long-lasting. So that's their base effect. However, it seems that they might have properties in the immunological context as well as the neurological context. There have been some studies looking at prevention of Parkinson's progression, both preclinical and clinical, that show some promise. And then there is possibility that, therefore, given the amount of effect it has on a variety of symptoms, some psychiatric disorders might benefit from it. It has, of course, been studied in the context of antipsychotic-induced weight gain, and I'll show you some data. But then there have been studies lately in the context of alcohol use disorder. A JAMA Psychiatry paper came out earlier this year, or last year, which showed some benefit in reducing alcohol consumption, some benefit in reducing nicotine consumption. And so a lot of studies are currently looking at GLP-1 receptor agonists across a wide variety of disorders within psychiatry and outside of psychiatry as well. These are the hot new molecules. But then for the purposes of my interest, I think that these molecules represent a strong tool to not only manage the metabolic dysfunction, but also to test the hypothesis of whether improving metabolic function can eventually improve cognitive function. And so if you look at the data available so far about GLP-1 receptor agonists, these are data pre-semaglutide, before, these are exenatide and liraglutide, which are the older cousins of this drug. There does seem to be an effect, so about 5 kilogram weight loss. However, these these are drugs which are less powerful than semaglutide. And so we currently have a CHR-funded study going on where we are going to examine semaglutide in a randomized blinded context in people who do not respond to metformin. And that, again, aligns with our thought and philosophy that GLP-1 receptor agonists should not really replace metformin. We do have a good answer in metformin in prevention and early intervention. And once people don't respond to it, or if that's not enough, then we should think of GLP-1 receptor agonists. And so we are about halfway through, and hopefully later next year or the year after, we'll be able to present findings. But in the meantime, we have clinical data. We run the metabolic clinic. It's a pretty large clinic with 500 new referrals a year. And so we have a chance to test these interventions out in real life while the evidence is developing. And so we published the first case series of the efficacy of semaglutide in the context of severe mental illness. And we found an average of 8.5% weight loss in individuals who had stopped losing weight with metformin. There were other related benefits to the lipid profile and the glucose profile. And somehow from all the work I've done, this caught the attention of a lot of people. And this paper was reviewed in New York Times and Newsweek. And essentially the story was that psychiatrists are starting to use obesity drugs, and why. And so that got us a lot of attention in terms of sort of making this story, making this argument that metabolic health is important to solve, and solving it can help with reducing other domains that we don't have solutions for. There was some concern with regard to semaglutide especially, but GLP-1 receptor agonists as a group, increasing the risk of suicidality. Further work has shown that this is likely not a big factor. It is, of course, individual reaction to drugs is difficult to predict, and individual clinicians should remain cautious. But this is a paper that came out in Nature Medicine 2024, where they were able to look at a large cohort of people and found that the risk of worsening mental health was not really there. In fact, mental health might possibly be improved. And then Toby Pillinger in IOP, they published this just a few weeks ago. Sorry for the small print again, but essentially they showed that GLP-1 receptor agonists, and these are studies where semaglutide was used in the context of obesity or diabetes. To be fair, in these populations, SMI was eliminated as an exclusion criteria. So these are generally mentally healthy people. But even in those people, use of GLP-1 receptor agonists was associated with improvement in mental health-related quality of life. And the risk of adverse mental health outcomes was shown to be not significantly higher in their paper. And so to summarize this objective, I hope I've convinced you that metformin is effective in preventing and treating antipsychotic-induced metabolic dysfunction. And the earlier you started, the better it's going to be. And that prevention is a safe and viable alternative, and that it can actually improve adherence and outcomes. And that topiramate is another alternative, and GLP-1 receptor agonists are exciting possibilities. However, I think in the age of GLP-1 receptor agonists, these older drugs do not fall by the wayside. I think we should use all the tools that we have available to us and sort of structure them so that we can use them in the best way possible. And so that is what we have done in our clinic, and I'll share some data from what we have been able to do. So these are the criteria for starting a pharmacological intervention in our system. So they go all the way from frank obesity on the top to concerns about metabolic side effects at the bottom, and the whole gamut in between. So we are able to start primary prevention, so metformin as a primary prevention in our early episode setting. We have had clozapine starts where as a policy now, metformin is offered when clozapine is being started. And so some of that data is now beginning to accumulate, and we are starting to see a change in prescriber practice in our system where psychiatrists and residents are more comfortable treating metabolic dysfunction. And the teaching to them has been from us is to equate metabolic dysfunction as EPS. If you're able to treat extrapyramidal symptoms with a benztropine, you should be able to treat metabolic dysfunction with metformin. Arguably, metformin is safer than benztropine. And so that's sort of been the structure we have used with our residents, and it is slowly taking hold. We have developed an algorithm at the metabolic clinic at CAMH. So on top, you see the criteria that were listed on the last slide. everybody who's enrolled is offered lifestyle approaches, and a dietitian is now available. And so they get the bare minimum. And a lot of people do stick to lifestyle strategies only. And I'll show you data on the next slide how they do. And then we ask if there are special modifying circumstances that might help us choose topiramate over metformin. 70 to 80% of our patients end up going on metformin because of the evidence. But for example, if there are comorbid eating disorders or residual psychotic symptoms, sometimes we are able to think of topiramate first before metformin. And then we wait for 2 to 3 months. The idea is to give them enough time to show an adequate response. Adequate response is defined as a 5% weight loss in the 3-month period. If that does not happen, then you cycle through drugs. So if metformin has not worked, you can consider adding on topiramate. Otherwise, you can go down to semaglutide if that's available and accessible and financially viable. The other agents that we have looked at in our clinic is oral semaglutide as well as SGLT2 inhibitors, given their evidence for weight loss in the diabetes field. Our experience with those agents has been mixed so far. And so the straight line down is our default paradigm in the metabolic clinic, whereas the agents on the side are used less often. And this is the evidence. So these data represent about 400 charts again. And so we have our overall clinic numbers. Overall, there appears to be a 3 kilogram average weight loss in the clinic after 12 months. But then if you look at number needed to treat to achieve 5% weight loss and 7% weight loss, which are clinically significant outcomes, you see that the clinic overall has a number needed to treat of about 3 for 5% weight loss. And then individual agents are in the range of 3 to 4. If you look at the semaglutide line on line 4 of the table, you see that even for 7% weight loss, the semaglutide's number needed to treat is about 2. These are rounded up figures like NNTs should be, but almost everyone loses 5% to 7% weight on semaglutide, whereas it's a bit more variable when it comes to agents like metformin and topiramate, which again represents this opportunity that people who don't respond to these drugs, you finally have an option where almost everyone will do well on the drug. Of course, there are side effects and of course there are downsides. We'll talk about that in a bit. But finally, we are at a stage where we have options. I mean, up until now, we never had options. Metformin and topiramate is all you had. And then if somebody does not respond to them or does not tolerate them, then we were left with no other options. Now we have pharmacological options which can actually rival the amount of weight loss that bariatric surgery causes. So this is an exciting world to live in. And then I'll show you some pilot data which connects metabolic health with cognitive health a bit more concretely. So these are data, again, Kate is going to present these in 2 weeks as a part of her thesis defense. So these represent 53 patients who lost weight in our metabolic clinic, and these are patients with mood disorders. So they were on a variety of agents, so this is not agent specific, but we found that the degree of weight loss was associated with improvement in verbal fluency. And so again, a very preliminary signal that improving metabolic health can actually improve cognition. And then we have these data which are currently under review. This is Whittle, one of my PhD students. And these data represent imaging data from 3 separate trials, one examining metformin, one examining topiramate, and one exenatide in 3 separate populations. And we used brain age, Sophia's tool, to see if change in weight is associated with improvement in brain age, or whether this can then be interpreted as improvement in brain health. And we found that, again, change in BMI was associated positively with change in brain age. And this was driven largely by the medication group. Our numbers are small, and this is a rather preliminary sample, but it does, again, show that improving metabolic health could be a way to benefit neural structure and cognition. And then sort of to go back to the neurobiological basis of this, what happens and why must we act early? This is Nicolette, who's, again, my postdoc. In her PhD, she looked at an interesting question. She asked whether antipsychotics could induce insulin resistance, not in the body, we know what it does in the body, but in the brain. Can antipsychotics induce brain insulin resistance with the very first dose? And so she took a bunch of healthy volunteers, and she gave them antipsychotics for 2 days, and then we scanned them, antipsychotic or placebo, and then we scanned them with intranasal insulin or intranasal placebo to essentially see if the brain registers the effect of antipsychotic early on. And what we found was this. So At the base condition, which is intranasal placebo, you don't see much happening in the brain. But when you give them intranasal insulin, there's a spike in the connectivity in the default mode and salience network. That has been shown in the literature. So this is how you know the brain is sensitive to insulin. You measure resting state before and after. But then if you give a single dose or 2 doses of olanzapine, that connectivity comes down significantly. This tells you that even from the very first dose, the antipsychotics are messing with insulin signaling in the brain. And this could underlie some of the appetite-related changes that we see early on with antipsychotics. And so this is worrying to me as a clinician. And then during the pandemic, we had to shut this study down. And we moved this model to a preclinical model, thanks to Maggie, who I work with. And in rat models, this is even more startling. I have these slides as a supplementary. I wasn't able to include it in the main presentation. But you see, across antipsychotics, a single dose of antipsychotics can block what insulin does in the brain. And that was startling to see. And this is an effect that is across all antipsychotics, at least in the preclinical world. In humans, we have been able to show this with olanzapine. We have now an extension of this study funded by PSI Foundation, where we are going to look at haloperidol as sort of the prototypical first-generation antipsychotic to build the argument that all antipsychotics can cause this problem from the very first few doses. And so taking all of this together, us and our collaborators across the world have come up with this new guideline that was published very recently in Schizophrenia Bulletin, which asks you, encourages you, challenges you to think about metabolic health in a much, much more proactive manner. And so if you follow this flowchart with me, the idea or the argument is that 8 out of 10 individuals who are started on antipsychotics will gain clinically significant amount of weight. And you have low cost, safe, reasonably effective interventions that you could try early on. And so what we are recommending is that while lifestyle intervention should be for everyone, if anybody is being started on high-risk agents such as olanzapine or clozapine, you straight away offer metformin. If anybody is being started on a medium-risk antipsychotic such as quetiapine, paliperidone, or risperidone, and they already have metabolic dysfunction, or they are young, so anybody in the first episode space, you should offer them metformin from the get-go. Only if you're starting a low-risk agent like an aripiprazole in somebody who's not young, could you afford to wait possibly. But even then, don't wait too long. Measure their baseline weight, and if the weight changes by even as little as 3%, think about starting a metformin. Because in general, in healthy people, weight changes are within a 3% range. And so that's the idea, that if you're having more than 3% weight gain after an antipsychotic was started, it is likely due to the antipsychotic. And so think about intervening. So if you put the first 3 bits together, at least in my practice, 90% of the patients would then be eligible for a coexisting metformin prescription, which is a marked change from where we are right now. Metformin prescription rates are low throughout the system, and we have been reluctant to start it. Also, patient acceptability is a factor. You might offer it, but the patient might not take it. And so those things need to be negotiated. And we have developed some strategies of doing that with more practice, both from the clinician and in the system. Then the uptake seems to be better. We have seen that with our early episode. The uptake of metformin in our early episode clinics is becoming better. And now if metformin does not work, or if somebody has developed obesity or other signs of metabolic dysfunction, then you offer GLP-1 agonists. And so that is the way we are proposing integration of these new drugs into this existing space. And so to summarize the objective, the third objective, an algorithmic approach to metabolic risk management is efficacious. Some of our data from the metabolic clinic shows that. It is currently being implemented as a part of a clinical trial in Denmark to study the whole model, if that is efficacious, and preliminary data do seem supportive. I would strongly encourage clinicians to think of a proactive approach, and we can have a discussion on why or why not this approach might work. And I think GLP-1 receptor agonists can deliver benefits beyond metabolic health, given the large effect size changes they bring about. And so the opportunities that exist with GLP-1 receptor agonists, to summarize the talk, is of course the weight effects, and they can improve cardiovascular health as a consequence, as we have seen in the diabetes or obesity world. They do not look like they worsen mental health on a group level. Of course, individuals differ, and we should be on our guard. And they may have cognitive benefits. There is some data out of the neurocognitive MCI literature, the Parkinson's literature, but we do have to sort of translate it to our context. And they overall may improve quality of life, given what we see with mental health related quality of life in those with diabetes. there are, of course, challenges. We really have no data in SMI. Dan Siskind will come out with the first clinical trial data examining semaglutide for clozapine, hopefully this week or the week after, and that's been accepted in Lancet Psychiatry, so watch out for that paper. There are gastric side effects, including gastroparesis and constipation. So again, with drugs like constipation, it can worsen. Drugs like clozapine, constipation can worsen. Interaction with ECTs is another thing that was unexpected, but now it seems obvious. In our system, if somebody's on semaglutide, they cannot receive ECTs. So they have to be off semaglutide for 3 to 4 weeks before the anesthetist feels confident enough to put them under because of the delayed gastric emptying. They're not sure if overnight fasting will empty their stomach. And so we have in our clinic patients who have to make this choice, ECT versus semaglutide. And unfortunately, some of them choose semaglutide, not ECT. I have patients in my clinic on disability payments of $700, $800. They choose to go on semaglutide. So they let go of the money that they need for subsistence to go on semaglutide. So that tells you how big and acute this problem is and how people suffer with metabolic health and the choices they make. Money tells you the weight they are putting in these choices. And so accessibility continues to be a problem. There are biosimilars coming out, and hopefully the cost will come down with time. And these may become a bit more accessible, although it doesn't look like it will go below $100 in the near future. And then there are, of course, concerns about length of use. How long do you use a GLP-1 receptor agonist? Metformin, for example, has been studied for decades. It's been around for 70, 80 years now. We know that metformin can be taken safely for 30 years, 40 years. People take it all their life, people who have diabetes. And so it's generally safe. We don't know that for GLP-1 receptor agonists. And so we don't know whether it causes cancer, it causes renal dysfunction, hepatic dysfunction. All of those are possibilities that need to be looked into. And the other disheartening part is the weight regain. When people stop drugs like semaglutide, all the weight comes back. And we don't know the physiological repercussions of that. That, by the way, is true for metformin as well. So in our trial where we have semaglutide for metformin non-responders, we stop the metformin so that we can study the effect of semaglutide in exclusion. And we thought that these people are not responding to semaglutide, to metformin. And so stopping the drug would not change anything. But then people who stop metformin also gain some weight back. So even though metformin was not causing weight loss, it was perhaps preventing weight gain. And so this is a problem with all weight loss interventions. The moment they are pulled away, we expect metabolic health to worsen. And so a lot of these interventions are likely forever interventions. And our field and our patients need to come to terms with that and sort of wonder what that means for them individually and as a group. So those are the challenges, I think, when it comes to the use. I'll stop here and thank the group that makes this work possible and all my funding sources. And I'm open to questions. Thank you for your patience. Oh, yes.
Hello, thanks so much for your talk. I had a couple of questions. First one was around the algorithm for CAMH for metabolics. And I noticed one of the aspects was if they have OCD, go to topiramate before metformin. And yet really, even in the recent systematic review, there was not a significant evidence for effectiveness of topiramate. And, you need to weigh different adverse effect profiles. So that's the first question. And then the second one is, to me, it kind of seems self-evident that if you're someone who has weight struggles and you lose weight, your quality of life will improve. When there's been reports of quality of life, is that, or around mental health, do they take into account just the effects of just the weight loss alone, as opposed to it being some sort of independent effect?
Yeah.
Semaglutide. Thanks.
Great comment and a great question. So the algorithm was put in place 5 years ago. And as we are publishing these data, we want to stay true to what we did as we were putting this algorithm in place. And back then there was a soft signal. So those indications for topiramate are all soft. They are based on single RCTs or some clinical suggestion that this might work in a particular context. And so in reality, 70 to 80% of our population does end up going to metformin. But we also wanted to position topiramate as a reasonable alternative so that people don't forget that, after metformin, there could possibly be topiramate, or there could be topiramate before metformin as well, given certain contexts. But your point is well taken. And in future iterations, we are thinking of removing the OCD bit at least. The question about the quality of life is a good one. And the simple answer is it's not really been tested in SMI populations. The data that I showed you was diabetes and obesity data and extrapolations from that, because they did measure quality of life. And they separately measured physical health quality of life and mental health quality of life, and they found improvements in both. However, this is a population that has been selected, so depression and any severe mental illness, any psychotropic use has been selected out already. And so these may not really apply as much to our population. It is an interesting question, though, but then I would like to flip it and ask you, as a clinician who will shamelessly take any improvement, does it matter? I want my patient's quality of life to improve at the end, and I will take all the mechanisms that bring her to that. But as a question, that's a valid question. I completely agree.
I'm reading off a question that came from one of our online participants. Some evidence suggests aripiprazole may improve metabolic profile in patients on clozapine. Is that worth trying, especially when other data shows IM aripiprazole plus clozapine may reduce acute hospital utilization? Yes.
Aripiprazole is an interesting drug. So the study that they're referring to is a population-level analysis that Jari Tionen's group published a year ago, I think, in Lancet Psychiatry, which showed that using aripiprazole as an adjuvant to clozapine reduces hospital rates. And the methodology seems fairly standard, and they do have a signal. And so that's something to consider in people who are not responding to clozapine. It's not that we have very many options anyway in clozapine non-responders. But when it comes to metabolic health, it's a bit more nuanced. It appears that the weight loss that was shown by two of the studies where aripiprazole was started as an adjuvant, in one of the studies, the weight loss was associated with loss of muscle mass rather than changes in fat. And so I'm not really sold on aripiprazole as a weight loss alternative. If you have another reason to start it, like your adjuvant for hyperprolactinemia or, again, clozapine non-resistance, you might think of it as a good option. But purely from a weight point of view, you have metformin, topiramate. These are much better research, much better known, and I would go for those rather than aripiprazole. Oh, yeah, at the back.
Thanks for the great talk. I had a quick question just on the patients who are maybe outpatient first episode psychosis who don't go on to develop like severe mental illness, and the antipsychotic is then discontinued. Are there data on how long potential antipsychotic-induced insulin resistance is sustained, with the implication being when to stop the anti-hyperglycemic?
Oh, right. So you're saying that assume that this person was on an antipsychotic, and in good clinical practice, you did start them on metformin, and then you're taking off the antipsychotic. When should you stop the metformin?
Correct. Yeah.
Yeah. So in these guidelines, the way we have written it up is that metformin is anticipated to continue for as long as they are on the antipsychotic. And so at least until that point. What happens after is not as well known. So the RADAR study came out last year, the year before, where they had a group where antipsychotic was deprescribed. And they found over 2 years that it led to a small risk and a significant increase in the risk of relapse, but no improvements in metabolic outcomes, even though antipsychotics were deprescribed or significantly lowered in dose. I would speculate that if the antipsychotic exposure has been short, then a short period of antipsychotic washout should take care of the metabolic problems. However, if they have been on it for a while, then physiology has been altered significantly, and that might take much longer. So I don't have a good answer to your question, except continue it until it's needed and then think about stopping it.
Thanks. And then just a quick follow-up. When the antipsychotic was started and you saw differences in the insulin kind of resistance, did that normalize after a certain period of time?
We didn't test that.
Okay, thanks.
Oh, hold on. No, I can answer that. So we had a washout period of 4 to 6 weeks between these 4 assessments. And we didn't see any residual effect at that point. So that's sort of the resolution I have. I don't know if it happens sooner than that. I'm guessing it does, because it's only 2-day exposure.
So you had an association between weight loss and changes in brain age. I'm just wondering how those changes would equate with the normal sort of brain aging curve.
Sophia would perhaps be a better person to discuss that. So brain age, so I will try to paraphrase Sophia, and I hope I get this right. The way the brain age calculation works is that it is a static calculation that is then compared to various people who have been imaged at various ages. We don't have the same cohort traveling through age to see how the brain age metric changes. Is that reasonable too? Yeah.
I guess, is it reversing something or is it just stopping aging?
No.
Now it works. So the brain age is the difference between a measure of your age based on your imaging data and your chronological age. Yep. So it's a gap. And as Mahavir just mentioned, this gap does not necessarily always increase in people, so it can remain static. But there are circumstances when it can go up, but also it can go down. So what Mahavir has shown is that if you're exposed to antipsychotic medication, for example, and other types of medication, these people have a higher brain age than the general population. But we have shown with a completely different group that if people go on calorie-restricted diets and they actually lose weight, you can see a change in the brain age going back to a more normal age for the population. So although it doesn't necessarily measure the pace of aging in each individual, it can give you an indication of whether it can change or not over a period of time.
Yeah, so in my rudimentary understanding, I interpret it as them becoming healthier, in that the gap is less with those interventions.
I have a question.
Yes.
Can you comment a little bit on the effect of the baseline weight of individuals, so before the exposure?
Yes.
Does it make a difference whether they're chunky to begin with or super slim?
Yes, so baseline weight is one of the bigger predictors of weight loss with an intervention. And so all our analysis tend to co-vary for baseline weight when you're looking at absolute weights, or we talk about percentage weight loss. And in general, yes, higher the weight, larger is going to be the absolute change in weight with an intervention.
Are the chunky ones higher risk of getting more chunky?
Oh, that is an even more interesting question. Yes, so we have limited data, but we find there are three trajectories. There are people who just genetically are not at risk of weight gain, and so they will just remain who they are in terms of weight, although there is weight-independent risk of diabetes as well. But in terms of weight gain, they stay steady. And these are data when we are looking at people who get started on antipsychotic 1, antipsychotic 2, and clozapine. So I'm telling you how the trajectory goes through that. So there are people who will never gain weight. And then there are people who will gain weight quickly and then plateau out. And that's represented in our various papers as well. There's a sort of shoot up between the first 12 to 16 weeks, and then there's a gradual plateauing, and people stop gaining further weight. And then there's a third trajectory, which eventually meets the second trajectory, but it's more linear. And so there's no shoot up. So they gain some weight with the antipsychotic 1, some weight with antipsychotic 2, and then another additional weight with clozapine. In terms of risk for weight gain, being female, being young, and being underweight seems to be the biggest predictors for weight gain, along with ethnicity-related factors which haven't been studied in as much detail. Yeah.
So I know that you shared with us some data about the one proposed interpretation of why these medications might have an effect on the brain, like with the insulin resistance, and you showed us that graph in the default mode and the salience network differences. Based on that interpretation or understanding, can you think of any other medications that might be helpful that we could explore that haven't maybe been discussed yet, or maybe other mechanisms that we could try to investigate further? I'm just curious about that.
Yeah, that's a very good question. So we are thinking of it as interventions that could sensitize the brain to insulin. And so then what are the interventions that could potentially do that? Metformin seems to be doing that. There are some data that metformin crosses the blood-brain barrier. I'm talking about direct effects. There are indirect effects as well. You could just lose weight and that would benefit, or you could exercise a lot and that would benefit. Bariatric surgery would help as well. But if you're thinking of things that would cross into the blood, into the brain through the blood-brain barrier, potentially metformin. GLP-1 receptor agonists, some of them do cross the blood-brain barrier. So 2% of the semaglutide dose that is available peripherally is seen in the CSF after 6 hours. There was a paper that came out. So it's a very small percentage, but given how potent these molecules are, possibly it's doing what it's supposed to do. Brain produces its own GLP-1, although it does not appear to be significant in weight management. And so we don't really know what happens when these exogenous molecules, which are long-lasting, suddenly find their way into the brain. Because endogenous GLP-1 has a very short half-life. There were studies early on where they infused GLP-1 continuously to see what the effect on appetite and things were that. It's that quickly metabolized. And so the engineering advance here is to make that molecule live. And so the CNS, if you think about it, has never been exposed to such a steady GLP-1 stimulus. And so that could potentially be one of the ways. Other molecules that have been examined are PPA1R receptor, gamma, so fibrates. They have been examined, but we haven't seen much of a signal with them yet. Intranasal insulin is very interesting also. So in MCI, there seems to be some signal that it might help. Alzheimer's disease not. It appears to be too late. It has been tried, interestingly, in schizophrenia in 3 studies, but people were already on antipsychotics. And so based on our data, we think that that was already being blocked. And I don't know if you could solve it and then give insulin, whether that might help. It's like a 3-step procedure to try it out.
Another question from online attendee. What role do negative and cognitive symptoms play in weight and metabolic dynamics in the early psychosis population?
That's a question that we are trying to look at in a meta-analysis capacity. There is association of worse metabolic health with worse cognitive health. And I think there's a paper back in 2000s sometime where they showed an association between poor metabolic health and worse negative symptoms, although I'm not able to recall it off the top of my head. But metabolic health and cognitive health are closely related from our work.
Hi, Dr. Agarwal. Thanks for the presentation. And certainly you're hitting on a topic that's very hard for us clinicians to get a handle on. So I'm quite impressed by the data you're getting with the metformin there with clozapine. Given that we're talking about other mechanisms and thoughts, any experience with Contrave, that combination, bupropion and naltrexone combination for the patients that you see?
Thank you for that question. An even earlier version of this algorithm had Contrave in it. And then we looked at some of the meta-analytical data, and it did not seem to be effective in SMI populations. However, our nicotine dependence clinic likes it very much, and they prescribe it because it allows them to think about smoking cessation without the weight gain associated with smoking cessation. So they use it much more than we do and seem to like it, because the bupropion helps with nicotine cessation, and the combination, reduces weight somewhat. In our clinic, we haven't had much success with it.
And just very quickly, in terms of the data, does it suggest that there's a dose correlation to the weight loss when we're talking about metformin and topiramate? Is that correlated?
We don't know. The minimum dose, it appears that the minimum dose is 1,000 milligrams. So you at least want to get there. And after that, we don't know. We tried to look at our data. The signal was not strong enough to be able to say. So as of now, the answer is perhaps not. But practically speaking, anybody who started on metformin and has way to go, we end up taking them through the whole dose range because they are already on it. So sort of, run out the whole runway before deciding to switch. And so a lot of our people end up being on 2,000 on average, and sometimes 2,500 as well. But that's the highest we have gone.
Well, thank you again.
Thank you.
Okay, good morning, everyone. We're going to get started on the next session now. So I'm Claire Beasley. I'm an associate professor in the department, and I'll be moderating the first set of lightning talks. The way this is going to work is that our speakers will have 5 minutes to present their data, and then we'll hold off on questions until the end, and we will get the panel of all 6 speakers up at the end to answer your questions. So I'm very happy to introduce our first speaker today. This is Dr. Abhijit Chinchani. He's a Marshall Fellow under the supervision of Dr. Todd Woodward.
Thank you, Dr. Beasley. Good afternoon, everyone. And today I'm going to be talking about the way or whether behavior funnels the electrophysiological effects of EACS to specific areas of the brain. So to begin with, what is transcranial alternating current stimulation? Here we use very low intensity electrical currents up to 2 milliamps with the aim of modulating brain oscillations and eventually behavior. Now, this method has gained a lot of popularity, especially because it's low cost, it's non-invasive, it's very user-friendly. I mean, come on, like what's not to like, right? And it has like very minor side effects. So it sounds amazing, but it has a lot of challenges as well. I think one of the main ones is that most of the findings in this field have not been replicable. And one of the main reasons why is that more than 70% of the electrical current just passes along this scalp, and a very small fraction actually reaches the cortex. And this leads to a very small magnitude of electrical field which is induced in the brain, and which is not sufficient enough to cause action potentials. But under optimal conditions, it may affect timing, which may lead to change in the phase of the brain oscillations. So the entire field is finding, or they want to find, what are these optimal conditions where we can find very reliable and replicable effects of EACS. And we are also contributing to answer this particular question. And the way we are doing it is we want to modulate alpha oscillations. Alpha oscillations are the most dominant electrophysiological oscillations in the brain. So what we aim to do is that we want to modulate them with EACS. We have a very simple experimental paradigm where a participant undergoes alpha stimulation and gamma stimulation on multiple days. We record, so that's the montage where we stimulate. Alpha oscillations are mainly observed or are dominant in the occipital region. So that's the electrode montage that we use for stimulation. And in the meantime, we also record like EEG signals before and after the stimulation is going on. And the main metric that we want to measure is the alpha power, because we want to see what happens to the alpha oscillations. The exact metric that we are looking for is what is the change in alpha power, which is the alpha after stimulation minus before stimulation. But not only that, what we are really interested in is the effective change in alpha power, which is likely because of the exact frequency of stimulation that we are giving. So that is our metric that we're going to look at. So what we observed in our data is that we did not observe an overall effect in alpha effective power, like change in alpha power, but we did observe a lateralized effect. We saw that the left electrodes had a lower increase in alpha power than the right electrodes. Okay, in an oddball experiment, and which we could see, and based on that, so what we observed was that most of the effect was because of the contralateral electrodes, and based on this, it was interesting because our electrode montage was not lateralized, but yet our effect on EACS was lateralized. Now, this was interesting, and which led us to believe into a hypothesis that behavior could modulate the effect of EACS on alpha. But we wanted to validate our hypothesis on an independent sample. And when we did that, what we observed was that, unfortunately, our results were not replicated. We checked it on like multiple different conditions, and in all of them, our results were unfortunately not replicated. So it seems that our results were our hypothesis was incorrect. So it's likely because of low amplitude of the EACS or intersubject variability. And what we're going to do is we're going to make our data set open source and like leverage it to test different hypotheses and see if that helps future experiments. Thank you so much.
Thank you. So our next speaker today is Katie Futhi. She's an MD PhD candidate under the supervision of Doctors Veronica Hirsch and Mark Sembrowski. Thanks.
Thanks. Thank you, Dr. Beasley, and thank you everyone for the chance to be here today. Okay, so schizophrenia is commonly referred to as the sort of graveyard of neuropathology due to its kind of characteristic, notorious lack of any replicatable brain signature. And so I'm going to be presenting some research today that actually for the first time relates some clinical symptoms to a postmortem brain finding. And so we wanted to look at cognitive symptoms in particular. And these symptoms were kind of what we wanted to explore further because the overwhelming majority of patients experience cognitive impairment. And it is the one sort of symptom domain that is not even remotely ameliorated by antipsychotic treatment. And so a way that we can really neatly explore neurological and psychiatric diseases is through postmortem brain tissue, which allows us to interrogate the human brain in a way that we just can't in a living human. And so when we think about cognitive impairment in postmortem brains, we think of Alzheimer's disease, cerebrovascular disease, and then we also think of other more atypical proteinopathies, which I won't get into. And so naturally, early hypotheses were that Alzheimer's disease was related to this cognitive decline in schizophrenia. But this has been proven not to be the case in study after study, which has replicated the findings that there are no increased rates of Alzheimer's in patients with schizophrenia. And so the role for these other pathologies, on the other hand, remains to be discerned. And so we wanted to explore this with this study, the underlying neuropathology of the cognitive impairment that is in schizophrenia. And so how we did this, we had a really neat cohort of 55 patients for which we had both prospective clinical data throughout life, as well as their physical brain specimens. And so this allowed us in a really unique way to analyze the autopsy findings and arrive at a diagnosis. And from there, we can predict the likelihood that this patient experienced cognitive impairment during their life. And then we're able to compare this prediction to what we actually saw clinically. And then we analyze this using sophisticated machine learning analysis. And so what we found first, what's really striking, was a dissociation broadly between the pathology that we saw and the clinical cognitive symptoms. And so take these two representative cases. This is a stain for an Alzheimer's protein tau. And on the left, we have a patient where we would not expect to see cognitive impairment. You can see very clearly there aren't that red stain there. And on the right, we would. And in fact, when we go to the MMSE scores for these patients, on the right, we see very severe cognitive impairment. And on the left, we also do. And so this sort of dissociation was not unusual in our cohort, with almost 50% of those that were impaired actually experiencing sort of this phenotype there, this cryptogenic cognitive impairment. And so to explore what was going on here a bit further, we clustered patients based on their neurocognitive testing profile. And so we had these 11 tests on the bottom there that sort of get at different cognitive domains. And this allowed us to group patients based on an impairment phenotype. And so what came out of this were 3 different phenotypes ranging from almost cognitively preserved up in the right corner in green to very severe global cognitive impairment. And when we strapped back on the autopsy data over top of this, we actually didn't see any appreciable differences between the 3 groups, further sort of reinforcing this disconnect between what we see in the brain and what symptoms people experience. And so to sort of look into this a little bit one step further, we thought, well, are there different relationships between the clinical and the pathology that are within each of these clusters? And in fact, one stood out to us, which was cerebrovascular disease, very fitting with our talk this morning. And so cerebrovascular disease severity was actually related to cognitive impairment, in that worse vascular disease resulted in worse cognitive functioning across the board. And this was actually specific to just one cluster, the intermediate symptom cluster in the middle. And so this has some really interesting implications. The first of which is that these neurocognitive testing or scores are clinically accessible tools that we can just administer easily in the clinic. And so if from there we can get at sort of a proxy for potential biological correlates, this has huge implications for treatment interventions in real time. And then secondly, again, as we saw again and again this morning, cerebrovascular disease or vascular disease is modifiable. And so blood glucose, hypertension, these are all levers that we can actually pull during life that potentially might sort of alleviate symptoms in the context of a symptom where there really isn't any relief at the moment in schizophrenia. And so I wanted to just thank everyone here, funders, and of course the tissue and patient donors and their families, without whom this wouldn't be possible. Thank you.
Thank you for that. Our next speaker is Dr. Tara Gardner. Tara is a PGY3 research track resident under the supervision of Dr. Tamara van der Waal.
So this morning, I'm going to present some preliminary results from an ongoing study that we're conducting looking at the effects of music listening on autonomic function in youth. And this work is funded by a couple of awards from the BC Children's Hospital Research Institute. So to start off with, it's well documented that dysregulation of the autonomic nervous system is a feature of psychiatric illness. With alterations in sympathetic activity, which is usually assessed by skin conductance, and decreases in parasympathetic function, which is shown by decreased heart rate variability. But there's also evidence that by improving autonomic function, we can improve psychiatric symptoms, such as through regular heart rate variability biofeedback, where it's been shown that if you can increase heart rate variability over the long term, this can improve depressive symptoms. Now, there's other studies that have shown that another stimulus that can increase heart rate variability, at least transiently, is music. And so we were sort of fascinated by the idea that we might be able to use music listening to increase heart rate variability and to use that to improve psychiatric symptoms. And we know that youth listen to music more than any other demographic, so that this would be sort of an ideal population for this intervention. But the studies that have looked at the effects of music listening on heart rate variability have only done so in adults. So our study aims to extend that work to adolescents. So our question then is, does music listening acutely alter heart rate variability, parasympathetic function, and skin conductance, sympathetic function, in adolescents? And of course, we're interested to know the answer to that question, both for kids without psychiatric illnesses and with psychiatric illness. And we also figure that probably the type of music is going to make a difference, and that we wonder whether it matters who chooses the music, if the kids choose it themselves or if we choose the music. So to answer these questions, we bring kids into the lab and we hook them up to record ECG, respiration, and skin conductance. And then we record why they fill out demographic and symptom surveys. And we use that as our baseline condition. And then they listen to pink noise, which is an acoustic control. And then they listen to 3 pieces of music that we've chosen with the order counterbalanced between those musical pieces, balanced between subjects. And then we ask them to choose a piece of music that they find relaxing. So that's a self-selected condition. And after each of the listening conditions, they fill out a mood scale. So we have data from the first 29 participants in this study. They're almost all control participants, so we can't say anything yet about psychiatric kids with psychiatric disorders. So what our findings have shown so far is that in terms of sympathetic function, we found that all of the listening conditions decreased skin conductance responses compared to the baseline condition. There was a trend towards some differences between the listening conditions, but we'll have to see when we have more participants whether those differences sort of strengthen or disappear, but they're interesting. For parasympathetic function, we were surprised to see that the pink noise condition was the only listening condition that increased heart rate variability over baseline. And unfortunately, because of our study design, pink noise was always the first listening condition. So this effect is confounded with an order effect. So as you might imagine, that we've changed our study design now to counterbalance in the pink noise condition with the other music conditions. But even still, what might be the reasons that we're not seeing an increase in heart rate variability like we expected with the music conditions? And we have some thoughts about that. Quite likely the whole experience is very relaxing for the participants. They come in, they sit in a comfy chair, the lights are dimmed, we have a lava lamp, I'm really nice to them. So we suspect their heart rate variability at baseline is already pretty high. We also think that we may see a different response in the kids with psychiatric disorders. And this is suggested by a recent study done in adults that was recently published, in which heart rate variability wasn't affected by music in control participants, but it was in participants with depression. So we may see a similar effect. So all in all, our preliminary results are sort of a tantalizing glimpse at what might be happening while we're listening to music, what's happening in the autonomic nervous system. And at this point, they raise a lot of sort of interesting questions, which we're excited to dig into. And I do have a poster on this if you're interested in more details. Thanks very much.
Okay, so our fourth speaker this morning is Mr. Paul Key. Paul is a research assistant under the supervision of Dr. Joe Tan.
All right, good afternoon, everyone. My name is Paul and I work with the BC Neuropsychiatry program here at UBC. Today, I'll be discussing how adverse childhood experiences relate to symptom severity and early symptom trajectories in patients with somatic symptom and related disorders, particularly looking at how these patterns differ between inpatient and outpatient treatment settings. Now, despite growing recognition in the DSM-5, research on functional neurologic disorder and somatic symptom disorder remains limited by the scarcity of prospective studies, particularly in tertiary treatment settings, where patients often present with severe, longstanding, and complex symptom profiles. The data that was used for this analysis was collected as part of the somatoprospective study, an ongoing 10-year prospective study that follows somatoform patients referred to the BC Neuropsychiatry program, a tertiary care program. This analysis includes 30 patients. We have 16 inpatients and 14 outpatients. And self-reported measures including the PHQ-9, BAI, PHQ-15 for depression, anxiety, and somatic symptom, respectively. Self-reported measures were collected at intake as well as during the follow-up appointment, during the year one follow-up appointment. Now, looking at overall symptom change across all 30 patients, depression and anxiety scores improved significantly at year one, but somatic symptoms saw no significant change. When we broke this down by treatment context, or down by setting, it became clear that these improvements were driven almost entirely by the inpatient group, who showed strong improvements across domains. Post-hoc analysis of the Friedman test for inpatients revealed that PHQ-9 and BAI scores significantly improved from intake to discharge, and these improvements were sustained at year one follow-up. Outpatients, in contrast, showed no significant symptom change over year one. Patients with high ACE scores, defined as 4 or more, had significantly greater somatic symptom burden at intake, with a median PHQ-15 score of 14 compared to 8 in the low ACE group. Depression and anxiety scores were also elevated at intake for high ACE patients, though these differences did not reach statistical significance, just trend level. And across year one, high ACE patients showed less psychiatric improvement, and trend level differences were observed between low and high ACE groups in PHQ-9 scores. Similarly, anxiety also showed trend level differences with more improvement in low ACE groups. Somatic symptom change, however, did not differ between groups. Linear regression modeling on the figure on the very right there. Linear regression modeling ACE as a continuous variable showed that higher ACE scores significantly predicted less improvement in PHQ-9 scores at year one. A similar modeling trend was observed for anxiety, while somatic symptom change was not significantly associated with ACE scores. And taken together, these results suggest that greater ACE exposure associated with higher initial symptom burden and blunted initial recovery in psychiatric symptoms, particularly depression, even when controlling for ACE as a continuous variable. While somatic symptoms significantly didn't improve over time, they were more strongly elevated at intake in high ACE patients than either depression and anxiety. This suggests that somatic symptom may reflect chronic trauma-linked processes that manifest early and remain relatively stable over time. Now, looking at how ACE effects vary by treatment settings, specifically comparing inpatients to outpatients. Among inpatients, ACE scores were not significantly linked to changes in depression, anxiety, or somatic symptoms. In contrast, among outpatients, higher ACE scores were trend-level predictors of reduced improvement in depression and anxiety. Regression models showed that ACE scores predicted less improvement in PHQ-9 and BAI scores with moderate effect sizes. We also looked at categorical ACE comparisons in outpatients. Here, high ACE patients showed worse trend-level outcomes in anxiety compared to low ACE groups. However, no significant differences for depression and somatic symptoms was found. Altogether, this suggests that the intensity of care matters, specifically with intensive inpatient care, intensive inpatient care may buffer the psychiatric effects of trauma, supporting earlier recovery regardless of ACE exposure. Overall, these findings highlight the importance of considering trauma history when planning for care for somatoform patients. Treatment setting appears to play a critical role in early recovery, reinforcing the value of trauma-informed intensive care models, particularly for those with more severe early adversity. While inpatients may benefit from structured interventions that buffer against ACE-related vulnerabilities, outpatients with high ACE exposure may struggle to improve in less intensive community-based settings. With only 30 patients so far, our findings are preliminary, but as we collect more data, we hope to strengthen statistical power and gain greater confidence in these observed effects. Thank you.
Thank you. Our next speaker is Dr. Laura Labonte. She's a psychiatrist and IMH Marshall Fellow under the supervision of Dr. William Honer.
Okay. So there's been a slight change in my title since I initially submitted my presentation. Previously, we were focusing on just looking at reliable change index, but since then, we've really worked on developing a minimal clinically important difference to evaluate outcomes in treatment-resistant schizophrenia. So I think over the last few decades, we've seen a huge shift in how we look at RCTs. We went from using purely statistical-based definitions of treatment response to now looking at more clinically relevant response, things that actually matter in terms of the lives of the patients and from treating physicians' perspective. In schizophrenia, we've traditionally considered a 20% improvement in PANSS score as a way of denoting meaningful change in symptoms and potential response to treatment. But over the last few years, there's been a lot of criticism regarding this standardized kind of definition. And there's been growing interest in how to define meaningful change, especially because it is so relevant when it comes to planning RCTs and defining sample size, how to interpret treatment group responses, and also how to see things, how they evolve over time, how do patients actually respond, and after the trial is over, what are we actually left with for patients? So in the late 80s, the idea of the minimal clinically important difference, or MCID, first emerged. And it was a way of having a new definition to really define the minimum amount of change that might be required in an objective score that would correspond to clinically significant change. So meaning that either the patient subjectively reports improvement or the treating physician identifies improvement for the patient. There has been a lot of research in terms of how you calculate MCID, and most of them have been strategized into what we call anchor-based or distribution-based approaches. For the anchor-based, basically in this method, we use a usually previously validated and widely used general measurement scale or scoring system to anchor responders and non-responders and look at how this compares to the outcome of interest or measurement tool of interest we're looking at. For the distribution-based approach, it's really just based on statistical methods, and there's a lot of different ones that are published. So the objective of our study was really to continue work in defining meaningful change in treatment-resistant schizophrenia. And we wanted to try to quantify an MCID for this population using PANSS scores, as well as looking how this may be applied in hospitalized patients with treatment-resistant schizophrenia. So we used two data sets in order to do this. The first one was patients with treatment-resistant schizophrenia that were participating in the clozapine and risperidone enhancement, or CT. For that particular study, we had PANSS ratings at days 1 and 7 while patients were on clozapine monotherapy, which allowed us to calculate intraclass correlation coefficients, which are necessary in order to calculate distribution-based MCIDs. And we did this for total PANSS scores as well as subscales for positive PANSS scores, negative PANSS scores, and general PANSS scores. Then we looked at patients with treatment-resistant schizophrenia that were part of the BC Psychosis program, and we used this data set to look at anchor-based MCIDs. For our anchor, we chose the Global Impression Severity Scale, which is basically a one-item physician rating of how severe the mental illness is for a patient. It's widely been used. There's a lot of evidence behind it. And what's helpful is that a predefined cutoff of response is just a 1-unit difference or more versus non-responders, which have less than a 1-unit difference. So we were able to compare CGI scores as well as PANSS scores at time of admission to BC Psychosis and at time of discharge. So for our participants, we did have patients with a mean age of 38 years, 26% were female, and the median length of stay for patients was 5 months. So when looking at an anchor-based approach for MCID, we really, as a first step, need to see whether the anchor we're using is valid. And so what we have to do is look at the correlation between change in PANSS score as well as change in CGI score and just the scores themselves at time of admission and discharge. And we did find statistical significance for all of this, which showed the validity of our anchor. So then we tried to look at 3 different approaches in terms of how to measure MCIDs. They vary slightly. One is to look at within subject change from time of admission to discharge in terms of their PANSS score. One is to look at between subject change, so those that have a response based on CGI of at least 1 versus non-responders, and look at their, the difference in their scores between admission and discharge. And then another one looks at the ROC curve in order to identify the MCID. And what we saw is basically for total PANSS, we could identify MCIDs that ranged between 3.4 and about 16.4. For the positive PANSS, we saw scores ranging between 4 and 4.98, and negative PANSS between 2.6 and 6, and general PANSS a change between 6 and 8.16. So when looking at our distribution-based MCID calculations, we looked at 3 different approaches. We looked at the RCI, which is the Reliable Change Index. We looked at the standard error of the mean-based measurements, and we also looked at the minimal detectable change measurement. And here we saw a kind of tighter range of scores for total PANSS, basically 11.8 across the board. For positive PANSS, 5.1 across the board. For negative PANSS, 5.7, and for general PANSS, 7.7. So as the anchor-based and the distribution-based approaches on their own have a lot of kind of risks and benefits, or not risks and benefits, but pros and cons, typically they recommend that you combine them and you really get a better appreciation of what MCID might actually represent. So when we combined all our measurements, basically we found that for total PANSS, we might see a reduction of 13.4 PANSS scores to be a minimum clinically important difference. For positive PANSS, 4.9, negative PANSS, 4.8, and general PANSS, 7.37. So we're still in calculation mode, but there was a recent paper published in Lancet Psychiatry last year where they tried to quantify an MCID in terms of identifying an increase in PANSS score that could signify illness relapse, and they did find a 12-point difference. So it is in a similar range of what we found in terms of our measurements. And right now we are looking at more ways of calculating MCID and trying to cross-validate between the two data sets, as well as looking at what our MCID might actually be predictive of when it comes to real-life clinical questions. So the one we're interested in is particularly improved in function after they've completed treatment. So that's the end of my talk. Thank you so much.
So our final speaker for this session is Ms. Karina Tisan. She's a PhD student in neuroscience under the supervision of Dr. Christian Schutz.
It's a long way down from up there. Hi, everybody. My name is Karina, and I'll be talking about how we've applied a machine learning model developed by Dr. Sophia Frangu and Yui-Tang Yu to examine how adverse life experiences and brain morphology interact to predict early adolescent substance use. So first of all, we know that the earlier that people use or try substances, the more likely they are to develop a substance use disorder. And we also know that early adverse life experiences are associated with adolescent substance use. Adolescence is a time period in which people undergo significant neuroplasticity and neurodevelopment. We see increased maturation of cortical regions that are associated with cognitive control and emotion regulation, which are associated with substance use disorders. And we also do see an increase in risk-taking behavior kind of at the peak of adolescence. And so Dr. Frangu and Yui-Tang Yu, they've developed this machine learning algorithm that can determine essentially where somebody's brain falls along this developmental trajectory. So how is their brain aging? And in other words, it's how does somebody's cortical morphology, does it suggest accelerated or delayed brain maturation relative to their chronological age? And so what we've done is we've applied this machine learning algorithm to data from the ABCD study. This is a large-scale data set that follows youth from age 9 to 10 years old for 10 years. The study is still ongoing. They're in about year 4 or 5 right now. And so what we did is we looked at their brain age or their basically brain development at age 9 to 10, as well as their reported adverse life experiences across 10 factors. And then we looked at their substance use up to age 13 to 14. And what we found is that when people were a little bit older at baseline, and also when they completed all data points, they were more likely to report substance use. But we also found that people with a lower socioeconomic status and lower neighborhood safety were actually less likely to use substances. We also found that this was the case for caregiver lack of supervision. So less parental supervision was associated with less likelihood of using a substance. And I'll explain a little bit why we think that might be the case. We also saw increased odds of substance use in the case of caregiver substance use and separation from the biological parent. We also found a significant interaction effect between brain predicted age difference and socioeconomic status, in addition to caregiver substance use and separation from biological parent. And so our post hoc analyses, we found that those with an older brain age had a steeper slope, essentially. So this effect was stronger for those with an older looking brain. And this was consistent across global brain age, as well as limbic and control networks, but not the salient central attention network. And so what we can see is that early substance experimentation is the norm, not the exception. We saw over 60% of participants reporting substance use by age 13 to 14. And also, you might be wondering why low SES and increased odds of substance use. This is actually fairly consistent with some literature that has found that alcohol use is associated with a higher socioeconomic status, and this may be due to access to substances such as alcohol, and most of the substance use in this case was alcohol. high caregiver substance use and separation from biological parent. That's fairly intuitive. Parent is more likely to use substances, child is more likely to use substances. And with more caregiver separation being associated with more substance use, we think maybe if kids are kind of engaging in risk-taking behavior, maybe parents are starting to monitor their kids more carefully, and maybe that's why we see this kind of surprising finding. What we also can understand from this interaction effect is maybe those with a higher brain age are more sensitive to environmental influence and group norms. And previous literature has found that as people enter adolescence, they may be more susceptible to motivational cues in the context, including kind of social motivators. So they may be more likely to follow their environmental trends. And this may also be dependent on network-specific development. So a few future directions include relating brain age and substance use to cognitive and emotional functioning. So for example, looking at that reward sensitivity, and then also looking at some long-term outcomes as the participants are aging, because this is an ongoing study. Thank you so much for listening.
So I'd just like to thank all of our speakers and invite them all to come down to the front to take questions from the audience. So if anybody has a question, please press your microphone and let the speakers know who you are addressing the question to.
Can I just ask a question? I think it's Pidget with the transcranial AC stimulation. Thanks for that talk. I mean, this is the first time I've heard of the transcranial AC presentation research. So thank you for bringing this up. You know, the power that you utilize, 2 milliamps for the AC stimulation, seems very low in the context of the impedance of the skull and scalp and everything else, right? And is that the usual power that these transcranial AC studies utilize?
Yes, and I guess in most cases it's even lower than that. It's like 1 to 2 milliamps. So yeah, wow, it's very low.
So basically, you have an AC electrical device of around maybe 6 volts or something like that, put on the top of the head as well as the occiput, and you're trying to. Is there evidence to say that such stimulation actually does anything? Because just thinking about from an electrical potential point of view, that sounds very unlikely, right?
So where there is evidence in like animal models and in vivo experiments that even low electrical fields, which is similar to what currents that have been applied, although they are not sufficient to generate action potentials, they may be able to change the phase of the brain oscillations. So that is possible, but again, like the mechanisms are not really well known.
Great, thanks. Yeah, thanks. Just in context, I just find it fascinating because when we do ECT, we're looking at orders of magnitude, the kind of power that we're talking about here. Thank you.
Hi, sorry, just a follow-up on kind of that topic. I'm a little bit curious. What about ultrasonic vibrations? Would that kind of have you done any research on that, or?
Yeah, unfortunately, I don't think I can comment on that because I've not done any research on ultrasonic.
What would happen if you?
Well, I mean, I think the obvious thing would be that it would increase the amount of electrical field which is induced in the brain, and which would increase the likelihood that it would generate action potentials and we would get much stronger effects. But it would also have other unintended consequences as well, right? So.
I have a comment for Karina and for Tara. Karina, when you look at brain age and you're looking at background in SES, there's a lot of evidence that for the body, that if you've been exposed to early adversity or come from disadvantage, you're going to biologically mature earlier. For example, you'll have puberty earlier. So it could be that what you're looking at with brain age might be related to disadvantage or bad experiences early. And it also might be related to differential susceptibility to that. So that those who are more susceptible to environmental effect might show that more in the brain, just like they would show it in the body. Just a comment. And Tara, we know that when you look at music in older adults, like with MCI and dementia, the music that works best is the music that they love. And I'm thinking about relaxing music with adolescents. And I'm wondering if that's the music that they love best. So even though you want to help parasympathetic, it might be possible that using the music that they love best might work better than relaxing music. Just a thought.
I had a question for Dr. Labonte, if I'm saying your name right. So it seems from your multiple analyses that you're sort of honing in on about a 15-point change, which given your baseline PANSS would come to about 15%. So then is one of those sort of understanding from your work that 20% might be overshooting and we might be losing molecules in the pipeline because of that?
Yeah, I think that's what one of the concerns that we have been thinking about, because 20%, I mean, if it varies so much based on the range of scores, right? We know that people with lower scores will need a smaller change to reach that 20% threshold. So I think the idea, that maybe it's, this is treatment-resistant schizophrenia, so we need a smaller, tighter kind of percentage change or point change to look at. And the idea we had was to get away from this percentage change and really kind of hone in on having a specific, a kind of a mean MCID with ranges in which an acceptable one could fall in.
Sorry, so then you're saying that you want to look at absolute changes and not percentage changes.
Exactly, yeah.
Right, but then if somebody, again, within the treatment resistance context, there could be a wide variation of PANSS. And so then the scales would be uneven depending on what the baseline PANSS scores are. And so then if you think forward, drug companies would then be will be incentivized to recruit the most severe patients, because it's just mathematically speaking easier to show a 15-point change in somebody with PANSS of 100 compared to somebody with PANSS of 60. I see your point, but shouldn't both exist? Like percentage improvement should still be a factor?
Absolutely. Yeah, absolutely. I think it was just because we're trying to find a kind of a complementary approach, right? Because there are flaws with the 20%, any kind of percent-fold change. And so this is just to get to, if we are looking at point-based change, what could be an MCID in terms of drug trials, what that will look like. I think maybe that's a question we should be asking ourselves in terms of the more severe illnesses and the more, the less severe patients. Maybe that's an important factor to be considering what their response is going to be like and what we actually should be considering in terms of meaningful change.
A quick question for Tara. Going with what Dr. Diamond asked earlier about the individuals and selection of their music. I'm curious because as a clinician, I find it interesting how idiosyncratic people are, right? Have you ever found objective evidence of relaxation, parasympathetic increased activity with music that you would never think, would be relaxing? Like, for example, if a patient chooses death metal or, hard rock, heavy metal, do you ever see that?
So, I mean, there's kind of two answers to that. One is that it has been super interesting seeing what music the kids choose. And sometimes I ask them around, and I wish I had put in a little qualitative part of this study to have them tell me why they chose that piece. The results in terms of parasympathetic function are really, really mixed. And I haven't looked on an individual basis at like in which kids and with which music we've seen effects of their self-selected music. That's still analysis still to be done. But there's definitely been some idiosyncratic choices. Like one kid brought in Guns N' Roses, another kid brought in like a Weird Al Yankovic song, and this is, I'll tell you the story because I'm sure he won't mind. But I said it's I was like, why would you, that's relaxing for you? As a kid that I knew. So I could ask him this. And he said, well, in our family, the rule is at bedtime, you're allowed to listen to one piece of music before you fall asleep. And so I always pick this Weird Al Yankovic piece because it's 8 minutes long. And so for years, he's been listening to this music as his bedtime music. So of course he picked that as his piece for this. So it's just so individual. It's super interesting. There will be an analysis of all those.
Yeah, just to say, for that 8 minute could be like stuck in a drive-through. I think is one of his songs that's very long. It's funny, right? Like the emotion is humor, and who knows? Maybe that correlates with it.
But it's with him. It's associated with bedtime, so that's relaxing. Yeah, super interesting.
I can ask one more. Pardon my single track mind, but Karina, do you have metabolic data in the ABCD cohort? And
Can look.
yes, please. Thomas Hayek has published a lot of work in the first episode psychosis world showing, as outside of psychosis as well, that poor metabolic health is a significant predictor of brain aging. And since that's your dependent outcome, and you're looking at socioeconomic status as well, so I'd explain more variability. Yeah, thank you.
Question for Abhijit. Have you contrasted the tax, the alternating current, with direct current stimulation? So what are the levels of, milliamps and things, and how well accepted is the direct current effects?
In my research, I've not done that, but I think looking at some of the papers, which I'm not sure if papers have actually contrasted that, but from what we know, I think the mechanisms are slightly different. Direct current stimulation seems to be just increasing the excitability, and the excitability is it's more or less fixed because it's not alternating. And in alternating, the excitability is alternating, which leads to which I guess the point is that may affect the brain oscillations at a particular frequency. So I guess that's the main difference. And the excitement with alternating current stimulations is that we can really modulate different brain oscillations, which is why it's exciting.
I just have a question for the presenter who was doing the brain age kind of stuff. Yeah. I'm curious, what is this might be a fundamental question or whatever, but what is the age, the brain of the age? How is that determined, and what is it based off of?
Yeah, so it's based off of predictive modeling. Maybe you can even chime in too, but it's predictive modeling based on, I believe, 5 different large-scale data sets. Do you want to maybe speak to that actually a little bit, since you had worked on that aspect?
So based on the large discovery sample for 35,000 individuals, based on a large discovery sample, it's more than 35,000 individuals, and we use this control mRNA to treat the people based on their age. But we have a specific model for 5 to 40 years old and 40 to 90 years old. Give it problems and if you like, the double. And the algorithm is the support vector motion with radio basis function kernel. So I can introduce more details afterwards and how we like something.
Okay. All right. Thank you.
Yeah, and to chime in on that too, it did seem to perform better than other algorithms out there. So that's always a nice bonus. Did that answer your question? Anything further?
Yeah, I have follow-up ones, but maybe I'll do that after.
Okay,
yeah.
Sounds good.
Do we have any questions online?
So this may be a comment rather than a question. I don't know if you have something to say to that.
Yes. So I think one of the main reasons for doing this research is that like there is a lot of excitement in the field about using these interventions, like for obvious reasons. And like one of the main reasons why we wanted to do it was we wanted to first validate whether these methods actually work, and if we could contribute to answering certain basic mechanistic questions as to what are the optimal conditions under which one can best use these interventions. And unfortunately, the initial set of results that we did find were not like really replicable. So I guess we'll continue to explore and see if it works.
Okay, I think we're getting close to lunchtime now, so we'll bring that to a close. I'm sure all of the speakers will be happy to take any of your questions over lunch or later on today. So first, can we give them all a round of applause? So a couple of announcements. Please don't forget to vote for your favorite lightning talk of the first set. You have until 12:30 to vote. As we heard earlier, please don't vote for anybody that's in your own research group. You want to try and spread things around a little bit. So if we can ask you not to do that, that would be great. And then I guess the other thing that I wanted to mention is the meet and greet at the end of the day today. So any trainees, psychiatry residents, grad students, come along and talk to some faculty if you have any questions about research. Or if you just want some free pizza, come along and we'll hopefully be able to answer some of your questions. So I think that's it from us for this morning. So you're welcome to go and get some lunch.
Well, welcome to the afternoon component of Research Day, and this is really my favorite event. After the 6 lightning talks we had this morning, I love the lightning talks. A quick way to get familiar with the research in the department and give the trainees and residents a real spotlight. And a couple of announcements. Please remember to go into the program to the QR code, which will link you to the Slido polls. And you want to give your poster scoring. When does poster scoring close? All right.
It'll be closing momentarily.
Oh.
Until 2:30.
2:30. Okay. So you got till 2:30. And remember, you shouldn't vote for people in your immediate lab. Recognize others. And then we'll also have lightning talk scoring. The first group should be available for scoring, and then we'll score this group. And okay, so our first talk is going to be by Miss Sydney Saint. And Sydney's a PhD student in experimental medicine under the supervision of Will Panenka. And she's going to talk about non-fatal overdose and brain structural changes.
Thank you. So for part of my research, I'm looking at brain structural changes after non-fatal opioid overdose. And today I will talk a little bit about some emergent volume changes that are associated with overdose. For context, there is nearly no longitudinal work that examines brain structural changes after non-fatal overdose. What is available is largely cross-sectional. There are a number of case reports, as well as at least one lab that I'm aware of has done a between groups VBM design comparing volumes, brain volumes between those with and without a history of non-fatal overdose, and they found decreased or lower volume in the group with a history of non-fatal overdose in the left hippocampus, which is congruent with what we would expect in hypoxic ischemic brain damage, which would be probably atrophy in regions of the brain where the neurons are most sensitive to hypoxia. So first and foremost, that would be, we would suspect the hippocampus and especially the CA1 neurons in the hippocampus, as well as possibly other subcortical regions of the brain. But for our analyses, the primary region of interest when looking at overdose-associated changes in volume. That was the hippocampus. And we also examined changes in the cerebellum, basal ganglia, and thalamus. Pictured there is the geographical source of the data and where most of the participants live. The methodological approach was a secondary data analysis of the serial brain MRIs that were completed as part of the hotel study, which ran for over a decade up until 2023. For those of you who are not familiar with the hotel study, it was a CIHR-funded naturalistic cohort study of health in over 500 marginally housed residents of Vancouver's downtown east side. And that was led by Dr. Bill Honer and colleagues from the Department of Psychiatry. And the downtown east side has been perhaps aptly dubbed the epicenter of the overdose crisis. In the hotel study, in addition to these serial brain MRIs, participants also self-reported recent non-fatal overdoses. And so there are 109 participants who have a self-report record of opioid overdose, and of them, 22 have an analyzable pair of T1 weighted MRI scans occurring before and after the overdose with less than 5 years between them. So for our analyses, we are looking at changes from the pre-overdose to post-overdose MRI within these 22 participants using linear mixed effects models. And then as a reference, we're using change in brain volumes in a comparable set of MRI scans that are not interrupted by an opioid overdose from 66 demographically similar hotel study participants that were matched 3-to-1. So then the term of interest is a group by time term in the model, and both groups on average have about 1 3/4 years between their scans. And the results indicate, significant differential change in left, right, and bilateral hippocampal volumes, such that those people who overdose between their scans show greater decreases between MRI 1 and 2 compared to the reference group. And the data is depicted behind me here. On the right-hand side is the change in bilateral hippocampal volumes for the reference group between their scans. And on average, when you don't overdose, they're losing approximately 25 millimeters cubed of volume. And then on the right with the red is the raw data showing the change in volume for the people who do overdose. And on average, they're losing 97 millimeters cubed of volume, which works out to mean 1.6% volume loss in hippocampal volumes for the overdosing group, compared to 0.4% mean volume loss for the reference group. And we're seeing a similar effect, a similar effect in the cerebellum on the right-hand side, where on average, the people who are overdosing lose over 1.5% of volume versus less than 1% of volume for the reference group. Then I think we conclude that non-fatal opioid overdose is correlated at least with volume losses in the hippocampus and cerebellum. And my next steps are to try and use the more limited amount of data that we have to do a completely within person analysis, as well as look at whether cognition and particularly memory might fluctuate with recent non-fatal opioid overdose. Thank you.
Okay, and so we'll hold our questions until the end. The next speaker is Dr. Gagan Singh, who is a psychiatry PGY2 resident in Vancouver and working with Rob Stowe and doing deep phenotyping in schizophrenia.
Hi, my name is Gagan and I'm a second-year psychiatry resident. I'm presenting on behalf of the majors team, led by behavioral neurologist Dr. Stowe and psychiatric genetic counselor Priscilla Carrion. So the majors project is a multi-omics and genetic counseling study of 50 comprehensively phenotyped research participants with treatment-resistant schizophrenia. or schizoaffective disorder, and they were recruited from the Provincial Tertiary Inpatient Clinical and Research Unit at BC Psychosis. What makes our project exciting are the high yield of clinically causative pathogenic variants as suggested by genotype-phenotype correlation and the translational precision medicine implications we present that help bring this work to life. So in our first 25 participants, almost 1/3 harbored likely disease-causative DNA sequence or structural variants related to their schizophrenia spectrum or their neurodevelopmental phenotypes. And so today I'll share the results in our second 25 participants. So in the interest of time, I won't go through the nitty-gritty of our kind of bench to bedside bioinformatics protocol, but in summary, DNA and RNA from whole blood participant samples were sequenced and aligned to the HG38 human sequence or reference genome. We used long-read whole genome DNA sequencing at 30 coverage to resolve complex genomic regions. Variants were then called, prioritized, and manually curated. In general, we encoded phenotypes using human phenotype ontology nomenclature and used a combination of phenotype-driven variant prioritization software and manual curation, including participant-specific genotype-phenotype correlation to identify clinically convincing disease-causative variants. So a strength of our study, A strength of our study is eventually returning clinically reportable variants to consenting participants and families via psychiatric genetic counseling, including ACMG secondary findings like breast cancer risk variants. Our cohort included 20 males and 5 females, and 15 had schizophrenia and 10 had schizoaffective disorder. Our participants featured neurodevelopmental psychiatric comorbidities, things like catatonia, autism, and intellectual disability, just noted in the corner. In total, 7 mechanistically potent rare variants underlying participant neuropsychiatric phenotypes were identified, each in a unique patient. So 3 were copy number variants identified by clinical chromosomal microarray, 3 were exonic DNA sequence variants identified by whole genome sequencing, and 1 was a pathogenic pentanucleotide repeat expansion identified by long-read sequencing and Straggler, which is a tandem repeat expansion calling and genotyping tool that our bioinformatician Indu developed and described in her Nature reviews and genetics paper just last year. So shout out to her. So our first case is a highly predicted protein damaging missense variant in ASH1L. ASH1L encodes a chromatin modifier involved in widespread transcriptional activation, in which protein truncating variants confer an 18-fold increased risk in schizophrenia per schema schizophrenia exomes meta-analysis. And haploinsufficiency in ASH1L is also implicated in autism and other neurodevelopmental phenotypes. So haploinsufficiency, in case you don't know, just means that one functional allele alone cannot maintain normal wild type function. So why does this finding matter? So Yan's team reported a rescue of ASD-associated behaviors hypothesized to be mediated by synaptic pruning deficits and ASH1L haploinsufficiency by adding an efferent A5 ligand to a pathway downstream of ASH1L. Theoretically, then, to rescue ASH1L haploinsufficiency, you may attempt to increase expression of the wild type allele. You may intervene at downstream pathways, or cleverly, you might try to inhibit those proteins that oppose the wild type protein's normal action, kind of like a double negative making a positive. So Zhu's team hypothesized the latter in 2016. ASH1L is involved in methylating histones. So inhibiting the corresponding demethylase, KDM2A, may increase the effective function of the wild-type ASH1L protein. But unfortunately, there's no known selective KDM2A inhibitors or EPH7 agonist treatments yet to test these hypotheses. So Gao's team in 2021, though, used vorinostat, which is a pan-histone deacetylase inhibitor that essentially makes DNA more accessible. And it's already licensed for the treatment of cutaneous T-cell lymphoma in Canada since 2009. So at much lower and tolerable doses were the doses used in the study, and they were able to rescue neuropsychiatric deficits in ASH1L knockout mice, which theoretically would be a more severe phenotype than haploinsufficient mice. So these data open up interesting precision medicine possibilities for ASH1L haploinsufficient patients. In a second case, we identify a protein truncating variant in SETD1A, which is the most significant protein truncating variant risk gene in schema, conferring a 20 to 30-fold increased risk in schizophrenia, depending on the cited study. So genotype-phenotype correlation, including facial morphology, strongly suggests that this H3K4 trimethylating chromatin modifier as a disease-causing variant as well. SETD1A is another example then of inhibiting the corresponding demethylase of a haploinsufficient methyltransferase to rescue a neuropsychiatric phenotype. Tranylcypromine is one of the LSD1 inhibitors that was used in the study and is a licensed antidepressant in Canada, but MAOAs can be clinically higher risk, as I'm sure many of you know. So we are excited to be collaborating with a group that's developed a more CNS selective non-MAOA LSD1 inhibitor with low toxicity in animal models and hope to begin phase 1 human clinical trials in early 2026. Furthermore, emerging evidence kind of suggests a role for common polygenic and epigenetic risks in schizophrenia and bipolar disorders, converging on SETD1A and LSD1, H3K4 gene ontology, kind of as hub genes, so regulators of common schizophrenia risk genes. And this positions LSD1 as a target in schizophrenia more broadly. So I'd like to thank the entire Majors team, our participants, our funders, and in particular, Industry Rajan Babu, Agata Miner, and Monica Heronchek for making this work possible. Thank you.
Okay, next we have Austin Lamb. And Austin is a PGY3 psychiatry research track resident working with Tanya Nichols, and is going to be talking about sort of profiles of sex offenders and victims.
Okay. Good afternoon, everyone. My name is Austin. I'm a third-year psychiatry resident in the research track working with Dr. Tanya Nichols in the Nichols Lab. And we've been working on a series of studies on sexual offending. So today I'll be talking about our study on sexual offenses, looking at specific victim and offense characteristics. So we know that men who have sexually offended are a heterogeneous population. So importantly, this can vary by victim characteristics, such as whether the person offended against an adult or a child, and by offense characteristics, such as whether it was a contact offense, such as sexual assault, or non-contact sexual offense, such as related to child pornography or indecent exposure. So our objective here is to examine differences between men who have sexually offended against adults, children, and both, as well as men who have committed contact sexual offenses, non-contact sexual offenses, and both, across clinical and risk-related factors. So our study sample is drawn from all BC provincial correctional centres between January of 2009 to September of 2017. So this is a population level data set. Our participants comprised of all the men convicted of sexual offences, so that number 2,479 men with convicted sexual offences during this period. Our measures consisted of the Jail Screening Assessment Tool, or JSAT, which is a validated structured professional judgment tool that screens for mental health and management needs, which is completed by trained screeners upon every single correctional admission to BC Corrections. And also the other measure is the BC Corrections Operations Network, or CORENET, which includes criminal justice information such as sentences as issued by BC courts. So we had done an extensive process of data cleaning to merge our JSAT and CORENET data sets. In brief, I'll summarize quickly here. We started with all the JSAT records, so that numbered over 148,000 JSAT records. We then went through a series of data cleaning steps, which you can see here. And then we got to our final sample of 2,479 men with the sexual convictions by including only the final JSAT record and screening in only the men with sexual offense convictions. So now on to our results. So starting with victim characteristics, we had nearly 1,300 men who sexually offended against adults, nearly 1,000 who sexually offended against children, and a little over 200 who sexually offended against both. What we found was that men who sexually offended against adults were more likely to have concurrent disorders needs, substance use needs, and it was the men who sexually offended against children who were more likely to have strictly mental health needs. Men who sexually offended against adults were more likely to have violence issues, as well as history of head injury and intellectual disability or brain damage. Now on to the offense characteristics. We had nearly 1,700 men who committed contact sexual offenses, 625 with non-contact sex offenses, and 155 who committed both. It was the men with non-contact sexual offenses who were more likely to have strictly mental health needs. The men with contact sexual offenses were more likely to have violence issues, as well as history of head injury, as well as intellectual disability or brain damage. So overall, our results suggest that men who have sexually offended against children and men with non-contact sexual offenses seem to have greater mental health needs and seem to be showing lower risk for violence. In contrast, their counterparts, the men who sexually offend against adults and the men with contact sexual offenses, may be more similar to their colleagues, the non-sexual violent offenders. So they may look more similar in profile in terms of clinical and criminogenic needs to the violent offending group. It is striking here that the men who have sexually offended against adults and with contact sexual offenses seem to show a greater history of past head injury and intellectual disability or brain damage. And this is consistent with the literature, which shows that there is a stronger association with traumatic brain injury amongst men who have sexually offended against adults as opposed to children, and men who have committed some form of sexual offense involving touching as opposed to no non-touch sexual offenses. So our findings may help inform the assessment and management of men who sexually offend by looking at their victim and offense characteristics. Thank you.
Okay, next we have Pei-Ying Wen, who is a second-year master's student and is supervised by Fidel Villa Rodriguez.
Hi, everyone. My name is Pei, and I'm actually co-supervised by Dr. Jason Snyder and Dr. Fidel Rodriguez. And this unique combination between contemporary neuroscience and psychiatry speaks to the very nature of our project, in which we studied the effect of electroconvulsive therapy on memory in animal model. More specifically, we found that electroconvulsive shocks impair the retrieval of long-term memory and disrupts the engram reactivation during recall. To start with, I would like to do a bit of introduction on the electroconvulsive therapy, ECT. It is a non-invasive stimulation intervention for affective disorders, but mostly major depressive disorders. A study showed over 50% of efficacy rate in medication-resistant MDD patients, which means if the patients are not responding to antidepressants, then ECT might be a very good choice for them. It's also widely studied in animals using the animal analog of ECT, which is called ECS, electroconvulsive shocks. That explains why ECS showed up in my title, not ECT. However, the wide use of the seemingly good therapy is limited by the concerns on cognitive side effects, the majority of which rests on the anterograde and retrograde amnesia. Comparing to the retrograde amnesia seems to be gathering mostly consistent evidence saying that it's transient and is followed by a full recovery, which might release some of the concerns. But retrograde amnesia remains a huge mystery. We don't know if it's permanent or it's transient, and when does it recover, and the neuromechanism underlying these cognitive deficits are still unknown. Which leads us to our project. Firstly, we wish to establish a behavioral phenotype of the ECS-induced retrograde amnesia, since it's very under-researched. We asked the question, would ECS-impaired memory decay over time? And would this retrograde amnesia recover? We are also interested in studying the neurobasis of retrograde amnesia. More specifically, since contemporary neuroscience believes that the engram reactivation, which is a group of neurons activated by the learning, will be reactivated again during memory retrieval, that supports memory retrieval we observe in behavior, is the mechanism. So we also asked the question, does ECS-induced retrograde amnesia reflect on a failed engram reactivation? We started by training the animal on contextual fear conditioning, which they receive electrical foot shock in a specific context. Then they receive spaced multi-session ECS treatment, mimicking a clinical schedule of ECT delivery in human. Then they were returned to the same context without any foot shock to assess for their freezing behavior, which is a manifestation of their retrieval of the fear memory. To start with, in the retrieval testing, we do see that the ECS-treated mice showed significantly lower level of fear memory retrieval, which is the same as what we observe in human. Then they were returned to the same context for 7 more days to assess for extinction. And we see that in sham group, showing the green line, that there is a decline in their memory recall across time, which was not observed in the ECS treated mice. Then 2 months after the last day of extinction testing, you can see by the gray bars, the sham controls showed a spontaneous recovery of the previously extinguished memory, which again was not observed in the ECS treated mice. ECS treated mice showed a consistently low level of fear memory retrieval across all the assessment. So putting together, we used the spaced multi-session ECS treatment and demonstrated the behavioral phenotype of a ECS-induced retrograde amnesia, including the impaired memory retrieval and a lack of extinction effect across time and a lack of spontaneous recovery, at least to the time of 2 months post-treatment. Then we examined the neurobasis, which is the engram reactivation. We again started by training the FOSTRAP2A transgenic mice in the contextual fear conditioning, followed immediately by the injection of 4-HT, which will label the neuron activated during this learning process with TD tomato. This is the advantage of using this transgenic mice model. We also stain the brain tissue for CFOS, which is a activity-dependent protein that will label on the neuron activated during the memory retrieval. In fact, we did see that the ECS-treated mice showed reduced cellular activation during the memory retrieval. And finally, we quantified the overlap of TD tomato labeling and CFOS labeling, suggesting that the engram cells were successfully reactivated. And we found that the engram reactivation rate is lower in the ECS-treated mice. So by examining the cell labeling, we found that ECS treatment reduced the cellular activation during retrieval and thus leading to a disrupt engram reactivation in dentate gyrus of hippocampus, which is in line of the failed memory retrieval we observe in behavior. So putting together this project established a behavioral phenotype of ECS-induced retrograde amnesia, and also provided the evidence for engram reactivation as the neuromechanism explaining this behavioral deficit. And that is all I have. Thank you so much.
Okay, our next speaker is Miss Andrea Wong-Koo, who's a graduate student under supervision of Michael Kraus and Roberto Sassi, and is going to talk about psychosocial factors and overdose.
So hi, everyone. Thank you for having me. So since 2017, BC has invested over $1 billion in addressing the opioid crisis. And but as we all know, the overdose death rates still remain high. So this may be due to fentanyl evolving patterns such as polysubstance use and new adulterants such as nitazene and xylazine, and as well as fragmented systems of care. So our 2023 cross-sectional survey study interviewed 255 acute care patients at the complex pain and addiction services at VGH with current or past fentanyl use. So today I'll present baseline findings on psychosocial factors, use patterns, and health interventions related to overdose risk. Data was analyzed using chi-square trend tests and bivariate ordinal logistic regressions. So participants were grouped by self-reported lifetime overdose counts in the different colors. Most reported 1 to 3 overdoses, and the highest group reported over 50. We used overdose cluster membership as a proxy for overdose risk and conducted sub-analyses for recent overdose risk in the past 6 months for 6-month related questions. So before I go over this, in terms of sociodemographics, identifying as females was associated with increased overdose risk, and overall the cohort was predominantly male, Caucasian, and middle-aged. While socioeconomic variables weren't statistically significantly associated with overdose risk, unstable housing, unemployment, and high school incompletion were high across all clusters. So considering physical and mental health, the highest risk group demonstrated the most adverse health and trauma profile seen in yellow, and higher adverse childhood event scores, physical abuse, suicidal thoughts, and attempts were significantly associated with increased overdose risk. Additionally, while chronic pain and mental illness were not significantly associated with overdose risk, both, along with abuse, were high across all clusters. In fact, 69% of the cohort had concurrent psychiatric disorders, telling us that these individuals are struggling lifelong and need integrated care. So now looking at key predictors from ordinal regressions, polysubstance use with fentanyl was high across clusters and significantly associated with increased overdose risk. While not shown here, smoking was the most common route of administration, and this shift from injecting in recent years points to a need for adapting to smoking-related risks, such as exposure to contaminants. In fact, the average daily fentanyl dose was 1.98 grams, far above the 2 milligram lethal dose, and this reflects higher tolerance and possibly declining fentanyl purity. So looking back here, most participants accurately perceived their overdose risk, but also they wanted to reduce use, yet fentanyl was often the only option available. Considering harm reduction, carrying naloxone and the uptake of administration supplies were highest in the high-risk cluster, possibly indicating greater risk awareness. Here, also use of overdose prevention sites was significantly associated with higher lifetime overdose, but not recent overdose risk. Additionally, drug checking was not significantly associated with overdose risk in reductions in either case. Overall, this raises questions on whether harm reduction, while widely used, is sufficient, especially without integrated systemic supports. So among substance use interventions, detox participation was positively correlated with overdose risk, likely due to relapse vulnerability post-detox, especially if not connected to other supports. CBT and Narcotics Anonymous had no significant associations, though 77% overall weren't receiving CBT. Lastly, opioid agonist therapy, or OAT, and safer supply drugs were accessed broadly, but neither significantly reduced overdose risk. This just also suggests a need to potential gap in dose tailoring and also integrating psychosocial care. So in summary, high polysubstance use and fentanyl smoking, coupled with declining fentanyl purity, highlight the need for updated harm reduction, OAT, and naloxone approaches. While widely adopted, current harm reduction strategies aren't significantly reducing overdose risk for this cohort, underscoring the need for integrating comprehensive care. High prevalence of psychiatric disorders, trauma, and chronic pain suggest self-medication and the need for trauma-informed, person-centered, territory-level care for comorbidities. OAT and safer supply drug uptake are not translating into reduced overdose risk, indicating unmet needs despite increased access. Additionally, detox alone may increase risks without long-term follow-up, and CBT access remains low. So overall, these findings really constitute a call to action. We need to evolve with the changing drug landscape. And this means to integrate services like supported housing, psychotherapy, clinical care, and harm reduction. We also need to update guidelines addressing polysubstance use, new adulterants, and fentanyl smoking. We also need to center care on individual needs, preferences, and trauma histories. And we also need to build and bridge capacity across health and social systems to ensure continuity of care. So lastly, for results that I did not show, feel free to visit my e-poster. And thank you for listening, and thank you for my colleagues, participants, and as well as Dr. Kraus, Dr. Nowczewski, and Dr. Sassy for their supervision and mentorship.
All right, and our last talk is by Mr. Yutong Yu, and Yutong is a PhD student under the supervision of Sophia Frangu, and it's going to be talking about biotype identification using machine learning.
Thank you, Dr. Murphy, and good afternoon, everyone. My name is Yutong. And today, we're very excited to be here to share my latest research about the impact of the data patterns on biotype identification using machine learning. Patient subtyping is getting more popular and is a cornerstone of precision psychiatry. So for example, depression is known to have many multiple subtypes, and a wide range of machine learning algorithms have been developed to identify them. However, results across different studies, sometimes they're inconsistent. And oftentimes these inconsistencies are blamed on the algorithm themselves. There's a reason that unexplored, which is the statistical structure of the input data. So this project in this study, our goal was to understand how different data patterns affect the clustering performance by leveraging synthetic brain morphometric data in a controlled environment. So we generated two main types of synthetic data sets. SYN1 and SYN2 are fully synthetic data sets that follow a normal distribution. And they were designed to simulate pseudo patients with 3 clusters. And as for the rest, SYN3, SYN4, and SYN5, those are based on real brain morphometric data from the Human Connected Project Young Adults. So in total, we have 1,108 healthy individuals, and we retained 508 of them to be the healthy individuals and modified the rest 600 healthy individuals into the pseudo patients by applying 3 global transformation patterns to some of the brain regions. So the transformations are monotonical increase, monotonical decrease, and mixed changes. So which means we modify some of the brain regions into the different directions so that they have the different complexity. So these transformations were actually designed to mimic the brain region alterations seen in the neuropsychiatric conditions. So for instance, some of the progressive volume loss in some of the regions and heterogeneous changes in others. So across all the data sets, we systematically varied factors like effect size, the cluster overlap, and the noise level, and also the number of clusters to comprehensively evaluate their influence on the model performance. And we also evaluated 4 clustering algorithms that are commonly used in patient subtyping. So first is Hydra, which is semi-supervised with convex polytopes. And the last is Sustain. So Hydra and Sustain are 2 traditional machine learning algorithms, whereas the 2 of the middle ones, like the Smile GAN and the Surreal GAN, those are 2 GAN-based deep learning algorithms. But overall speaking, these models just represent a diverse range of popular approaches right now in patient stratification and clustering. And in terms of the result, so in the figure, each subplot shows accuracy across different data sets and the conditions, as well as the variations. So we have varying the number of clusters and comparing the equal versus unequal splits. And the first figure we have here is the result from Hydra. So as we can see, Hydra actually showed a highly variable performance across different variations. And it's actually the accuracy is ranging from 0.45 to 0.99. However, all these fluctuations cannot be fully explained by the known characteristics of the data itself, and could be impacted by some of the other hidden features as well. And for the second algorithm, Smile GAN, it performed the best in the SYN1, which is not in this figure, but with 99%. And it retained also a relatively high from the SYN3, but as we can see, it dropped significantly on SYN4 and SYN5. And basically, what the all failed means, it just the algorithm does not give us any of the result, so it failed to converge. Surreal again, the next algorithm was relatively stable across most of the scenarios, but it does show a sharp drop in accuracy on the most complicated data set, which is SIN5 on the last figure here. It is because it contains the mixed changes, like the both increased or decreased brain alterations. So it is as expected. As for the rest of the last algorithm, sustain, which is not listed here, it is because it failed to converge. It was unable to generate any valid result due to its computational limitations, and therefore it was excluded from the comparison here. So in summary, the dataset structure does have a major impact on clustering performance. So even when using these advanced machine learning models, and these findings underscore the importance of benchmarking use of synthetic dataset with known ground truth before we actually apply these algorithms into the real world patient data. And also, since this study, we used the brain morphometric data, it actually extends far beyond the neuroimaging data. So we have different modalities of data, for example, the gene data, the clinical features, all those kind of data can be incorporated into this analysis as well. And ultimately, this work just highlights the need for rigorous validation and better alignment between algorithm design and the data they're applied to. So thanks for your attention.
Okay, now I'd like to invite all 6 speakers to come down for the Q&A. Questions?
I have a question for Sydney. You talked about overdose and the effect on the hippocampus and the cerebellum. And I was wondering if you have data on whether it's high level of opiates or whether it's the actual trauma of the overdose.
So I haven't specifically we do have data to most participants have really reported their 5 weeks days and what opiates they're using. I haven't analyzed brain volumes with respect to that, but the reference to overdosing match on their average opioid use frequency and also part of their scans, their approximate. So, sort of answer the question.
Is frequency the same as level of dose? No. Okay.
Okay, Lynn, you guys can come up to the microphone.
Okay, so I had a question for Pei Yang. It looked to me like there was some difference between males and females and reactivation of engrams and also ability to recall the memory. But maybe was it significant? And if you increase numbers, do you think you'll see something? And any speculation on that?
Thank you for the question.
Hey, why don't you come to the Zoom people here?
Of course. Thank you for the question. With regards to sex difference in the first experiment, limited by the conditions, we don't have enough number of mice of each sex in each condition to add sex as a factor in the stats analysis. Simply by looking at the data in a numerical way, we don't really see a huge, like a consistent difference between sex in the first, like the behavioral data. And in the second experiment, where the cell labeling and engram reactivation, this time we had enough number of each sex in each condition to actually run sex as a factor in the stats, and there is no stat significance.
I have a question for Dr. Lam. Was there a specific intellectual disability that was more prevalent among perpetrators?
No, the variable was pretty broad in terms of how it was measured, because this is used as a general broad intake screening for BC corrections. So in the jail screening assessment tool, the item it's quite it's not very detailed, so we're not able to break that down.
I guess I have one for Sydney. What's the criteria for overdose? Do they have to be resuscitated?
Not necessarily. The self-reported overdoses that we are used to define overdoses, they did either have to have received naloxone and they report that, or have had it treated in the hospital, which probably, in all likelihood, they would have also received naloxone or Narcan.
I had a question for Gagan. It's pretty cool that you guys are picking up such high numbers of genetic anomalies within that population that you're studying, schizophrenia world. When you look through all of those variants and anomalies, is there a specific test in there that it really highlights, this is something that potentially could be useful to pick up most of these cases, and whether, from a cost perspective, this is within the realm of clinical use at any time in the near future?
Yeah, thanks so much for your question. So maybe I'll start with the second part in terms of cost. So I think one part of our study, one high yield kind of component from our study was that 7 out of 25 of our patients in the second cohort featured a variant that based on genotype phenotype correlation, we thought was likely disease causative in this patient. And 3 of those patients, about half of those patients, did not feature a comorbidity. And so one of the things that, we did wonder about was the potential utility of whole genome sequencing in these patients, even if they have kind of a primary psychotic illness in the absence of neurodevelopmental or intellectual disability diagnoses, because for those, sometimes, a clinical chromosomal microarray is sometimes used to kind of identify those variants that might be associated with their phenotype. As with any kind of new technology, as things kind of develop, things become a little bit cheaper, things become a little bit more efficient. At this stage, I'm not entirely sure on the health economics, but maybe my staff could speak a little bit on that. And then for the first question, could you remind me what the piece of that question was?
Well, I think it was just basically about, which of the tests, because I believe there's a panel, there's a variety of testing that you're running through, right? Which
yes.
is highest yield if we were to look at, one test.
Interesting question. Yeah. So I think one of the strengths of our study was how deeply phenotyped our patients were, and how we kind of correlated that to their genotyping. So in terms of phenotyping, I think it would be difficult to do a subgroup assessment to say that this was higher yield or that another aspect was higher yield in terms of the phenotyping, because we used a lot of different exams we used a lot of different methods to phenotype the patient, like multidisciplinary diagnostic rounds, structured neurology, or neurological interviews, and then dysmorphologic exams as well. And in terms of the yield, though, of genotyping, when we used clinical chromosomal microarrays, which we saw 3 variants in, versus whole genome sequencing, which we saw 3 DNA exonic variants, we haven't looked at kind of intronic or like splice variants yet. We identified 3, and then 1 was a pentanucleotide repeat expansion. So if your question is between should we use a clinical chromosomal microarray versus a DNA sequencing approach, I think based on our sample, it would be hard to kind of come to a conclusion on that, just because there are only 50 patients in our sample. But maybe my staff could give a bit more detail on that. Yeah.
Maybe I could just comment on that. Thanks, Gagan. And thanks, Joe, for the question. So first of all, from a practical standpoint, clinical chromosomal microarray is covered now through hospitals' global budgets at BC Children's and the Royal Columbian Hospital Molecular Cytogenetics Lab. Any specialist can order a chromosomal microarray screen, so there's no cost associated with it. Going forward, the costs of whole genome sequencing are rapidly coming down. There are 2 companies in the US that are offering clinical whole genome sequencing for $500 Canadian, roughly. So, clinical whole genome sequencing is capable of detecting CNVs as well as as well as point mutations and indels and the full range of genetic abnormalities. So I think that, in the next 5 years or so, we're going to see this becoming much more commonly ordered. The quality of some of those whole genomes done for $500 is open to question. They use extensive AI tools to do the genotype-phenotype correlation and not a lot of manual curation, I think. And so they end up with a fair number of false positives. That's what I'm hearing from colleagues in medical genetics.
Okay, more questions? You have a Zoom question.
So the question is the reduction of overdoses.
Overdose versus not. And also, is the hippocampal volume loss associated with number of overdoses?
Thank you for the questions. I'm not sure that I have a good answer for either of them. I haven't looked at whether there is more a dose response effect, whether or not there is more hippocampal volume loss with an increasing number of overdoses between scans, but there is a small amount of data that I could look at that. And the first part of the question, I'm sorry, I'm not sure that I'm quite clear on. Could you repeat it?
Does the reduction in hippocampal volume from overdoses lead to clinically significant differences between patients who overdose versus those who did not?
Whether the difference in loss is clinically significant, I don't think that I can comment on.
That was the only Zoom question? One more. Yeah, why don't you read that one?
It's not clear who the question is addressed to. What is electroconvulsive therapy supposed to address? And what brain area function does it affect? And is poor memory retrieval in your study possibly a positive outcome where it can decrease the effect of traumatic memories or experiences?
Thank you for the question. I believe it's for me. So the therapeutic effect of electroconvulsive therapy is actually based off the seizure high frequency brain activity that this electrical shock induced to a human brain. So the shock is actually delivered, well, there is multiple ways in placing the electrode, but the basic idea is to deliver a shock to generate a brain-wide seizure. So there is not a specific brain area that is targeted. As to the side effects of being considered as part of the therapeutic effect for you forgetting some of the past experiences containing negative emotional effects, there are early clinical studies that investigated the correlation between the content of, well, the severity of the amnesia and the therapeutic effect of ECT, and they didn't find a correlation here, which means that if the amnesia is supposed to serve some sort of therapeutic role, then you would expect the patients that have more memory loss will show a better symptom improvement in depression, but it was not the case. So people think that, plus there is never evidence for specificity on what type of memory that got forgotten, except that it's more likely episodic rather than semantic memory, but it's never correlations been found regarding to the emotional value. So to this point, most people think it's very low possibility. Yes. Thank you.
Okay, not seeing any other questions from the audience. I have a ton of questions for the speakers, maybe after the session, but I'd like to thank all 6 speakers.
All right. Good afternoon, everyone. We are moving on. It's time for the faculty lecture presentations. It is a pleasure to be introducing Dr. Mahesh Menon, a clinical associate professor in the Department of Psychiatry at the University of British Columbia, and registered clinical psychologist with Vancouver Coastal Health's BC Psychosis Program. He is the co-chair of the Schizophrenia Program under the Division of Adult Psychiatry and Mental Health Services in the Department of Psychiatry. His research interests span really, the full biopsychosocial realm. including cognitive and neurocorrelates of delusions and hallucinations, as well as psychotherapy and psychosocial interventions for psychosis and severe mental illness. His research has been funded by the CIHR, the Ontario Mental Health Foundation, the Mind Foundation, the Vancouver Coastal Health Research Institute, and also NARSAD, the National Alliance for Research on Schizophrenia and Depression. His primary clinical focus is on working with individuals struggling with severe mental illness, including severe and recurrent depression, bipolar disorder, and those recently discharged from inpatient care. He has been involved with the ongoing development of metacognitive training for psychosis, MCT, which I believe he will be discussing in more detail with this presentation. The floor is yours, Mahesh. Thank you.
Thanks, Joe. So I'm not actually going to spend a lot of time talking about MCT, even though that is something that we are adding to our pilot project. But I wanted to talk a little bit about this initiative that we are rolling out across British Columbia, because I'm quite excited about it, and I think it's a great thing to have as part of our routine clinical care. So I have no significant disclosures. I want to acknowledge that the land that I live and work on is the traditional and unceded territory of the Coast Salish peoples, including the Musqueam, the Squamish, and Tsleil-Waututh nations. The reason why we are interested in an intervention like cognitive remediation is because cognitive deficits are actually a very reliable finding in schizophrenia spectrum disorders. And we can think of these as a core feature of the illness. In fact, when the DSM-5 was to be rolled out, there was a lot of debate and discussion about whether we should include cognitive symptoms as part of the cluster itself. But due to the lack of specificity there, that was not included. But it's really important to recognize that a vast majority of our clients who are struggling with schizophrenia spectrum disorders will experience some cognitive impairments, and the magnitude of these does not really correlate with the severity of positive symptoms. And when we look at the magnitude of the symptoms itself, this is from an old study, but the thing I want you to notice is essentially that those the open squares are the first episode population, and then the blackened squares are a more, in quotes, chronic population, so more than 5 years into the illness. But what I want you to notice is, first of all, that the magnitude of deficits is largely between 1 and 3 standard deviations below the control mean, which is really quite huge. And the pattern of deficits that we see is very similar between the first episode and later in the illness. And this is an old study, but really the data has been replicated and been quite consistent here. And when we look at like some of the big ones, we see these huge effects on attention, verbal memory, abstraction and flexibility, processing speed. And all of these cognitive deficits, in turn, play a fairly significant effect on daily life functioning. So this is data from a structural equation modeling paper from Chris Bowie and colleagues. And what we can see here is that those domains are having an effect on social competence, functional competence, and people's ability to function in the community, independent of negative and positive symptoms. And when we look at work, independent of like really the other core psychopathology itself. So we can say that these deficits are actually a much better predictor of daily life functioning than actually the magnitude of delusions or hallucinations that the person might experience. And we can think of these, the 5 Ps as we call them. These deficits are pervasive across the illness. They tend to be persistent over the course of the illness for each individual. They tend to present early. So there is kind of a 2-hit process that's happening here, where oftentimes prior to the onset of the first episode in that prodromal phase, people talk about having these cognitive difficulties. They progress, as we could see that 2-hit that was happening. So within the first few years of the illness, there is further cognitive impairment that is occurring, and they are predictive of the functional disability itself. So when we are looking at it, and I'm going to do a little bit of fMRI hand waving here, but basically, there is no part of the brain in schizophrenia which is kind of impaired or damaged in the way that we might see with like ABI or TBI or stroke or anything like that. But when we look at, so this is data from using what's called the Sternberg Working Memory Task. It's a very widely used task. This is a study from our lab from Paul Metzak and Tolf Woodward. And this is a task where someone's in the scanner and you're doing a working memory task with 2 letters, 4 letters, 6 or 8 letters. So the task gets more challenging on some trials and it's easier on other trials. And then we can look at what brain networks are active. So for this one, we used an analysis tool called CPCA, which Todd has developed. And I don't really want to get into the details of this at all, but basically what I want you to notice is when we look at the graph on the left, you can see what is called a dose-dependent relationship there. Essentially, there is increasing brain activity as the task gets harder. So when you go 2, 4, 6, and then when you get 8 letters, that brain activity is increasing in those brain networks to allow the person to do it. For the patients, which is the graph on the right, you can see, as the task is easy, there's less brain activity, but essentially when it gets a bit harder, like 6 letters, 8 letters, you've sort of maxed out on the activity itself. And so when those activation limits are reached, essentially we start to see performance deficits. So there's no difference between our patients and controls at like 2 and 4 and even 6 letters, but then when you get 8, they're unable to do that. So our hypothesis here is that it's essentially inefficient processing, potentially inefficient connectivity between different key nodes in those brain networks and regions, which is what's driving the cognitive challenges that are observed. So perhaps increasing network efficiency could then help to improve performance. And this is where cognitive remediation comes in. CR is an intervention that targets cognitive deficits in those domains like attention and memory and executive functioning and so forth, using the principles of learning to ultimately improve functional outcomes. And what the data suggests is that the effectiveness is enhanced when it's done in the context of a larger psychosocial program itself. So, some of you may have seen for a while, there used to be all these ads for Lumosity and all of these computer games where you can just do the computer games and it's supposed to help your brain and help prevent dementia and all kinds of things. And it turned out that a lot of that was perhaps overhyped. So just doing computer activities isn't really going to help enhance cognition unto itself. However, the components of CR, when we think about it as a structured clinical intervention, do involve kind of working with a therapist where we can kind of link those cognitive problems to the goals that the person wants to work on. Having the computer exercises, that's a part of it. And again, I'm going to do the hand waving and say, like, we think that that is increasing neuroplasticity, potentially network connectivity, and so on. But the other 2 key elements of CR are, one is developing better problem-solving strategies. So monitoring what we're doing, monitoring where we run into challenges, and can we use strategies to enhance performance and really prune ineffective strategies and flexibly use strategies and so forth. So this is a very kind of top-down executive functioning driven approach to CR. There are other bottom-up ones, but this is the kind that we are thinking about. And in the context of that executive driven approach, we are thinking about ways to facilitate the transfer from the kind of computer activity that we're doing over to the real world itself. And that's a key part of bringing that benefit to whatever real life activities the person is keen to work on. I just want you to know that, this is not like a new idea. The last meta-analysis from 2021, 2022 had 130 trials. It's got robust effect sizes across most of the domains of cognition, and interestingly, even on functioning and symptomatology. So because this is a robust, well-studied intervention that is not widely used in clinical practice, we were interested in finding a way to roll that out. The ministry was very supportive. And so in 2022, the Ministry of Health and the Ministry of Mental Health and Addictions funded a pilot project that allowed us to set up what's called the advanced practice here at BCH, develop pilot sites in each of our health authorities where we could actually hire clinicians who would just have time dedicated to doing this. Not a lot, like 1.6 FTE, but do the training, and then we run a weekly community of practice for the clinicians to ensure fidelity, problem solve, help people kind of get going, and so forth. And so this is all of our different health authorities, as well as we have PHSA sites. So we had a mixture of rural and urban sites across the different health authorities. The PHSA sites are at Redfish and the Forensic Psychiatric Hospital. And our side at VCH is actually at the Squamish Mental Health team, the Sea to Sky team. I'll skip over that. The approach to CR that we have used is called action-based cognitive remediation, and it was developed by our colleague Chris Bowie over at Queen's University. And this one, in keeping with those kind of what would be considered gold standard components of CR, has the computer activities as well as versions of real-life tasks that clients do in session. So I wanted to just show you what that looks like. The group itself has 4 modules: attention, memory, executive functioning, and social cognition. And each module has 4 sessions. And the 4th one is sort of dedicated towards goal discussion. So helping, again, link what the client is doing in that particular module towards the goals that they might be working on. And we wanted to demonstrate the effectiveness of this. So we also have an intake where people do a bunch of questionnaires as well as some screening measures of cognition and the goals themselves. So each session has a bunch of different computer activities. We use a program called Scientific Brain Training Pro from a company called Happy Neuron. I think that might be the most buzzwords that you can get packed into a name. It's actually a wonderful program. So they have about 40 different computer exercises, and they use an errorless learning model. So you have to get perfect on one level, and then you bump up to the next level, and so on. And so this is an example of one of the exercises from the executive functioning section. So this is a computerized version of a fairly widely used task, which is called the Towers of Hanoi or the Towers of London task. And the goal is you want to move those rings from those pegs to match the pattern that you'd see on the top right-hand corner there in the fewest number of moves possible. And you can't put a big ring on top of the small ring. So you can't, for instance, put the blue ring on top of the purple ring on the right-hand side peg. Now, on a longer task, we sometimes get people to work through this, which causes a little bit of anxiety. But I want to think about the idea that we start off usually like just brute forcing, like just moving things across. And then if you did that, you could get it, but it wouldn't be the most efficient way to do it. So actually what does make it most efficient is when you take it and break that down into a series of smaller problems. So really the first one is, how do I get that blue ring from the middle peg over to the right-hand side? And I can break that down. Then the next one would be, how do I get the yellow one on the extreme left over on top of that? So we can take a big problem, break it into a set of smaller problems, which, as you can see, has a lot of real-life applications as well. So the transfer tasks for each activity, which we do in session, takes that approach, that spirit, and gets us to think about, how do I use this strategy in a kind of a version of a life activity? So the transfer task for this one is one that's called Everyone's Off Sick. And you're told to imagine that you work at a hardware store and a bunch of your colleagues are off sick. And we've got little stations which are set up, which have like hardware, pain samples, bills and receipts, and you're supposed to help out all of your colleagues a little bit. So you have to kind of go through and work on each of these things. So you're trying to sort things out by size and keep track of the numbers of them, or sort out bills, receipts, invoices, or like pain samples, which ones are damaged, which ones are on sale, which ones have been discontinued. And you're told, I don't want you to just stick on one station. You want to kind of move through all the 3 stations as well. So you are trying to think about kind of adaptively using different strategies, as well as kind of monitoring the total duration you have, when to pause and when to switch, and so forth. So it's actually quite a lot of like planning, inhibition, task switching, monitoring, all of which are really kind of executive heavy. So we wanted to kind of have that structure, and we wanted to offer it to as many people as we could. So the funding was originally from the EPI part of money, and it was meant to be for people with schizophrenia spectrum disorders. But we said, like, if you're connected to an MHSU team and you are noticing you're having cognitive concerns, by all means, come join the group itself. So the project's been running for a few years now. We started running the groups in 2023. And so the data that I have are from the first 2 years of the project. And in the first 2 years, we had about a little over 500 people go through the program. And the mean age is about 35. And they've been unwell for about 8 to 10 years. had many hospitalizations, including for many people in the last year. And the ethnicities are fairly representative of BC, and the diagnoses are quite varied. About 2/3 or half to 2/3 were kind of schizophrenia spectrum disorders and psychosis, and then another third were mood disorders and other diagnoses. And about 30% of the sample were working or volunteering when they entered, and about 14% were in school. So the data I'm going to show you are from a subgroup. At the time when we stopped and just started kind of pulling the data to do the analysis, about 300 participants had completed the group. There was about 85 attending, and 130 had dropped out, partially due to work or school demands or becoming unwell or in a crisis. And again, about 20% had lost interest in the group itself. But the people who continue, enjoy it, they find we had very high client satisfaction ratings for the people who stuck around with the group. They felt supported. They thought that it was helpful for their cognitive health and helping them kind of work towards cognitively challenging goals. And overall, it was a really positive experience for a lot of our clients who were doing this. So we want to show you actually some of the results from it. So this is a group that is just being run in routine clinical practice. This is not really part of a study. But we have a wonderful group of really engaged clinicians who were supportive of this idea. And we were trying to use these measures both for treatment planning as well as program evaluation itself. So as a measure of sort of objective cognition, we used a screening tool. It's similar to like the R-bands or a slightly longer version of something like the MoCA. And it's called the SCIP, or the Screen for Cognitive Impairment in Schizophrenia. And it has a list learning task, a working memory task, a fluency task, which looks at kind of executive functioning, and then the delayed recall and processing speed itself. And we get individual subtests, as well as a total score, which is converted into a Z-score. And because, well, as with most screening measures, those of you who are psychometric nerds might know, like, total and composite scores tend to be a little bit more reliable than subscale scores, but we can kind of delve into those as well. But when we look at the pre and post scores, so pre-group, the Z-score was minus 1.7, so kind of near that -2 standard deviation score that we saw from the Sakin paper, really kind of what was expected. And then post-group, we see the score as minus 0.9, so a really 3/4 of a standard deviation improvement, and really kind of it's pulling it up from the mild, moderately impaired over into the low average range. So clinically, it's a huge jump that we're seeing. And as you can see from the effect size calculation there, it's kind of medium to large, just falling shy of what we would call a large effect size of Cohen's d of 0.78. We also gave people the trails, and they improve on that as well. Again, kind of small to medium effect size that we see. We asked people about their subjective cognition, like, do you find any changes in how you're feeling in terms of your thinking skills and abilities? And we used the PROMIS scale. So that asks questions like, I feel like my mind's been as sharp as usual, my memory's been as good as usual, and so forth. And again, we find that pre-group to post-group, there's an improvement. And then we also went back and asked anyone who was willing to fill out the survey 6 months later. And the folks who did the survey 6 months later actually continued to see that benefit on subjective cognition as well. The big thing for us as our measure of functioning was we used what's called goal attainment scaling. And GAS is essentially where the clinician that's working with them at the start of the group is trying to gauge what goal is important to you. So for instance, let's say the person says, I'm hoping to be able to go back to school. Now, going back to school in an 8-week group or a 16-week group is probably quite an ambitious task. That might not be realistic, but we might say, okay, my goal is to actually start to take an online course and to be doing that course 3 times a week. So as you get to know them, you might say, okay, yep, that's your expected goal. What would be beyond that? What might be below that? And we kind of plot that out objectively at the start of it. And then at the end of the group, we go back and review what was the goal and the progress towards the goal itself. So it's really individually tailored goals and looking at those different markers. And then you chuck it all into a spreadsheet and you get T-scores that pop out of it. And what we see was, as expected, that kind of from where they are before going into it, to when they finish, they are actually able to achieve the goals that they were working towards. So that 50 point means that they achieved the goal that they were, and we actually see about a half a standard deviation improvement. So a bunch of people were actually overshooting that goal and able to do a lot more, which is actually also really comforting to see. And as you can see from here, the effect size is huge. It's like 1.5 standard deviations up, so Cohen's d of about 1.5. We also had people complete a self-report measure of symptomatology. So this is called the Modified Colorado Symptom Inventory. And it looks at questions related to depression, anxiety, as well as paranoia, suspicion, hallucinations, and so forth. And we see that people report that kind of moderate symptomatology there. And then after completing the group, this was a real surprise to us. We actually got a reduction in symptomatology across all the 3 domains of a large effect size. And these improvements in symptomatology actually persisted 6 months later as well. So that was a really positive and unexpected finding for us. We think it might have to do with actually people connecting with other people, having a sense of self-efficacy, working towards those goals, and really kind of getting out into the world itself. And then we also looked at a measure of psychological well-being using a tool called the QPR, which was developed from service user accounts of variables that are important to them. So this asks questions like, I feel better about myself. I feel like my life has a purpose. I feel like I'm motivated to get better and so forth. And again, there's that improvement, which persists 6 months later as well, which was really kind of nice to see, a medium to large effect size. We offered the group as virtual groups on Zoom as well as in-person groups. And we can see that both when we repeated the measures, splitting them up and kind of did ANOVAs, we see no main effect of format or outcome by format interaction. So both virtual and in-person groups are equally effective. And when we looked at the stage of illness, we looked at people within the first 5 years of the illness versus kind of people who'd had a duration of illness of longer than 5 years. We again did those repeated measures, ANOVAs, and we found no main effect of the illness stage. There are some effects where there's an interaction between the illness stage and the variables, say on the MCSI and the QPR, with EPI clients showing a larger improvement itself. So really that's saying to us, it's beneficial for both EPI and non-EPI clients, but as we would expect, we want to get them earlier in the course of the illness to prevent more cognitive deterioration from occurring. So our takeaways, hopefully we've made a case that this is really effective when delivered in routine clinical practice by trained clinicians. It was really well received. Both virtual and in-person versions are effective, and we're seeing these benefits across a whole range of outcomes. And so now we're hoping that we can kind of roll it out and make this a permanent program. And when we think about the structural factors which are helpful, having clinicians who have time dedicated to it is, of course, very, very helpful towards getting those numbers in. We're also creating communities of practice and supporting the clinicians as they roll it out, and finding ways to provide ongoing training to clinicians is really beneficial to them. So now we've kind of started to add on additional training so that they can offer programs like the metacognitive training that Dr. Tam had alluded to, as well as kind of we hope to then kind of add on like job skills and so on moving forward with this. We've also created an online training portal, which we think will be helpful. Thank you so much. And I actually just wanted to acknowledge the wonderful team with the advanced practice, as well as all the clinicians that I work with and my lab, some of whom are here. We kind of like blend the research and clinical components together. Thanks.
Thank you, Mahesh. As usual, very thoughtful and informative. Let's take 5 minutes for some questions before our next speaker. Any questions on the...
Thanks for such a nice talk. I had a good question. So I was wondering kind of in terms of cognitive remediation, like, are the goals like developing adaptive new functioning, you seeing kind of cognitive decline, or is it kind of scaffolding problem solving strategies for like important activities? And then kind of follow up to that, over the course of illness, how do you envision cognitive remediation is kind of delivered to patients? Do you think they would need booster courses kind of throughout the course of their illness?
Yeah.
And would the previous exercises contribute more to far learning versus near learning? Yeah.
Yeah, so I think that around the questions of like, what are the goals? We ultimately are really interested in kind of where the rubber meets the road, right? Like, are people able to make gains towards the goals that they are interested in, right? And a part of why we're thinking about having these multiple interventions, which are a part of the suite of services offered, is so that we can kind of like develop a really holistic formulation. What are the barriers to functioning that we see? So there are going to be some clients for whom cognition is going to be the primary barrier, and so CR might be the best intervention for them. There are going to be clients for whom paranoia is going to be the sort of primary barrier, and we might see kind of something like MCT as being helpful for them. We might kind of want to add on, other kind of things going forward around things like improving social cognition, for instance. But we hope that the combinations of interventions that we offer will ultimately allow people to get better. What we can see is here, even just from having one intervention, we see fairly kind of robust effect sizes. So ultimately, if people's cognition improved, but they weren't able to do more with their lives, it wouldn't really matter as much. It is about kind of getting people to do more. But that sort of to the second question, it is probably like exercise. Like people are practicing those computer activities and thinking about strategies and meeting with their clinicians and doing all of that quite regularly. And that's what's beneficial. Everyone has access to those activities even after they leave, and we've been kind of wanting to have alumni group where people can come back and kind of meet with other people and the clinicians to just talk about it, but they have access to the computer games even after discharge from the program. So we think that that is something that would help. Long-term effects, past 6 months, kind of when we get to a year, 2 years, I'm not sure. There is some data from the research that suggests that it's effective, but there's so few studies that I'm not sure. I do think that ultimately it's going to be like physical exercise. You're going to have to keep doing stuff to stay sharp and kind of keep those gains going.
Thank you for the talk. I'm really impressed with this action-based cognitive remediation. I hadn't heard of it before. It seems like it could be beneficial to many more groups besides those with just schizophrenia and bipolar.
Absolutely.
Howard Feldman, when he was here, was interested in cognitive remediation for frontal temporal. You could imagine it for dementia and mild cognitive decline. You can imagine it for all kinds of groups. Is this being used for other groups here?
Yeah. So, I mean, because I have time and we have a few wonderful clinicians that we can dedicate towards doing that right now, we have really been trying to kind of explore what are the possibilities. So we had looked at kind of having clients, who may have concussions. Many of our clients will also have comorbid substance use issues that are coming in. We have a bunch of clients who have ADHD or ASD as comorbid diagnoses. And my hope was, like, if you're keen and interested in doing it, by all means, come on in, right? We have enough room to kind of do it right now. And then we can do the subgroup analysis, because my hope with kind of like at the policy end of it is that we can kind of take it back to the ministry and say, here's where we're seeing kind of bang for our buck and benefits to it. And we can try to expand it out into sort of some of those specialized programs. So right now we're actually looking at the Foundry to look at kind of high risk clients, young people who may have prodromal psychosis, as well as potentially other diagnoses which are bringing them in, and also trying to look at whether we can get at older adults in that kind of MCI range. It turns out that our older adult programs, people get referred into those only when they actually have like a dementia, which is kind of progressing to sort of moderate or beyond, which would be hard. But if we can get the folks with late life depression, MCI, I think that would be great, because actually Chris had a recent paper that came out with the CAMH group that found that it was actually quite effective in delaying transition kind of from healthy to MCI, as well as MCI to stage 1 dementia.
Great. One follow-up question. I really love the idea that you have the transfer test, because that's very important. Now, you're talking about different age groups now. And the transfer test, like the one you mentioned with the store and putting things, was appropriate for some groups, but not. So are there a variety of transfer tests to choose from?
So for the most part, we have like one transfer task per session. We encourage people to really try to think about like, this might not be exactly what you're doing now, but what are some of the components from this that you're going to take away? So like there's another one, which is like a dinner party where you're told, you've invited a couple people and then they want to invite a couple more people. And one of those people has a dairy allergy. So now you got to go back and look over all your ingredients in your pantry. And we have a little pantry built out. So we're like, okay, you might not cook, but this is a good chance to kind of think about those and kind of think about the big picture, fine detail, and so forth. But when we were working with our young people, sort of like first episode and kind of high risk populations, we did have to adapt the language and kind of did create a few of those which are really kind of a little bit more tailored towards young people. But for the most part, it's been mostly, but with a few additional choices.
Any questions online there? To miss anyone? No? Okay. If I may, just one last question then. In terms of the longitudinal histories, speaking only for schizophrenia now, in terms of longitudinal history, when it comes to cognitive impairment, what does that look like? Is it primarily in the earlier phases of the illness? And if you can speak to whether we can jump in, like double down on the cognitive remediation at an early phase, is there any evidence that this is perhaps disease modifying, or at least because I'm quite impressed by your modified Colorado score, right?
Yeah.
Like that 6 months later,
Yeah.
that they still had an improvement.
Yeah.
That's phenomenal. But yeah, any thoughts about that? Because schizophrenia does seem to have almost like a developmental trajectory to it.
Yeah. So again, I'm going to do some hand waving because I think we have data kind of from the first episode with CR. There may be some studies which have looked at it in high risk populations, but I'm not familiar with that. But really just kind of thinking kind of psychologically in the run up to the first episode. So typically in kind of the 2-3 years before seems to be where we are starting to see increasing cognitive concerns. So before someone develops a first episode of psychosis, they will often, like family will look back and say, they stopped going to school. They were really struggling with attention. Their grades dropped. They weren't able to kind of concentrate and do the things that they wanted to do. And then that also has these huge knock-on effects on things like self-confidence, their kind of ability to engage socially. So there's kind of more social isolation that's happening. So if we could get to them at an earlier stage, and if that was corrective, I could definitely see that as being protective in some ways and hopefully changing the illness trajectory, because I think the longer people isolate themselves, the worse some of the sort of flattening and negative symptoms could also be. I think people, when they're isolating themselves, also tend to self-medicate by like smoking more weed and using more substances. So we can hopefully have some ways to kind of prevent that deterioration the earlier in the illness trajectory we'd get. So yeah.
Thank you. As usual, very thorough. Thank you so much, Dr. Menon.
Hi, it's my pleasure to introduce Dr. Apuya Azar, who's a clinician scientist in the field of pain and addictions. He is currently a clinical assistant professor in the department, but as Dr. Yatha mentioned, he will soon be joining as academic faculty in the field of concurrent disorders. In his work so far, he's pioneered a number of treatments, novel protocols for the treatment of opioid use disorders that have been adopted worldwide, which I believe he'll be talking about, and is currently the principal investigator of the first RCT comparing buprenorphine naloxone rapid induction with standard induction. So yeah, we're very fortunate to have Dr. Azar here today.
And thank you so much for having me here. It's a distinct honor to be presenting today. And I appreciate everybody staying after a long day to sit through another presentation. So I want to acknowledge that the land in which we are gathered today is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I want to start with the statistic. I'm not going to delve into the epidemiology, but this is something that strikes me every time I read it. And that's that overdose deaths are the leading cause of death in British Columbia for persons aged 10 to 59. So more than homicides, suicides, accidents, and natural disease combined. So this speaks to the gravity of the situation that we're dealing with in British Columbia. And this is really what all of my research is focused on, is coming up with new solutions to clinical problems that we encounter in the age of fentanyl. I can tell you that the youngest patient I've had who's died of an overdose was a 13-year-old boy. The oldest was a gentleman in his 70s. And I've had patients anywhere from people who are struggling with homelessness in Vancouver's downtown east side to physicians' children, to young professionals, and everybody in between. So we've always had addiction in British Columbia and worldwide, but what's the difference? And really it comes down to the molecule that's being used now, and that's fentanyl. So fentanyl, as many of you know, is 50 times more powerful than heroin. And fentanyl analogs, so new molecules that are now showing up on the streets, are upwards of 500 times more powerful than heroin. So you can imagine that with the onset of fentanyl, we've started to encounter new clinical problems that we've never had before. I can remember when I first started my addiction medicine fellowship in 2013, I decided to go into addiction medicine because I enjoyed the pharmacology. And I really was not expecting to lose too many patients. And that was the first year that we started to see fentanyl come on the scene. And at the end of that year, I had lost count of how many patients I had lost. It was particularly challenging because I worked a lot with youth and adolescents. So it became, painfully evident that we lacked some of the clinical tools that we needed to address this problem. So my research really sort of focuses on the patient journey. So the patient journey starts with when a patient comes through our door and they're using fentanyl, the first thing that we encounter is the need for detox or withdrawal management. So a patient comes in, they're tolerant onto opioids, they're in opioid withdrawal, and we have to treat their withdrawal first. Secondly is now that their withdrawal has been managed, we have to start them on treatments for opioid use disorder. So that's opioid agonist therapy. We have to come up with new ways of starting these medications. And what our lab has come up with is something called rapid opioid agonist therapy, which we'll go through briefly in this presentation. Okay, so now somebody's on opioid agonist therapy, the treatment for opioid addiction. Retention is a problem. Now, retention in British Columbia in 1 year of treatment is about 16%. So the vast majority of patients who start opioid agonist therapy will not remain on opioid agonist therapy. So we have to come up with ways of ensuring that patients will remain on treatment. And of course, patient and family engagement is extremely important because we cannot treat our patients in isolation. And then at a certain point, it struck me that all of our research was focused on patients who had addiction to begin with. But what about preventing addiction in the first place? So then we started to focus on primary prevention. We've come up with some interesting strategies in that area, which I'll talk about. And then enhancing public safety is something that's interesting, that's often not talked about in medical research. But part of the question is, how do we ensure that our population is safe as a whole when it comes to the threat of opioids? This sounds quite vague, but we'll talk in a little bit more detail around how we've addressed this through pharmacology in our lab. And then education. We can come up with as much knowledge as possible, but if we're not training the next generation of scientists and clinicians, this knowledge is not going to go into the hands of patients. And this is graphically sort of represents what our research program looks like. And essentially here we have IMAP, which is the name of our program in general. And then we have IMAP Clinical, which is all the clinical research that we're doing at Vancouver General Hospital. And then we have IMAP Science, which is the UBC scientific arm of our research. So that's us working hand in hand with researchers at UBC to help us solve clinical problems that we've encountered with our patients. And this is super important for me, and this is what speaks to the concept of translational research. And that's because we come up with clinical problems when treating our patients that we don't have clinical tools for. For example, withdrawal management. There was a time back in the good old heroin days when a patient came into hospital in withdrawal, all we would have to do is treat them with morphine and hydromorphone, and they would be okay. We would be able to get them out of withdrawal and start opioid agonist therapy. This was about 10 years ago. that became more and more and more difficult. And we had to come up with new ways of treating withdrawal. And we had to come up with new ways of starting opioid agonist therapy as rapidly as possible. So we needed new ways of developing these clinical tools. So we had to reach out to the Department of Chemistry, the Department of Pharmaceutical Sciences, to come up with new strategies to treat our patients. So this is applied basic science research. I would go to the Department of Pharmaceutical Sciences, and I had asked Anil Maharaj, who is a professor there, to computer model what our current protocols look like and how we can achieve more rapid, more efficient, effective protocols. So here's an example of that exact thing. I'm not sure if I have a pointer here. So here we have an example of applied pharmacology where we had a protocol that we developed based on the pharmacokinetics of buprenorphine, which is a medication that's excellent for opioid use disorder, but very difficult to start in patients because it actually paradoxically causes withdrawal. So the first line, sort of the bumpy line here, and I appreciate that most people in the audience may not be clinicians, so I'm going to kind of try to describe this in the clinical context as much as possible. So the first line here, the bumpy line, it's serum levels of buprenorphine that we achieved through a homegrown protocol that we've developed. Now, each bump represents one dose increment. And for this protocol, we had to dose the patient every 3 hours for the first 24 hours, and then every 3 hours for the second 24 hours. Now, this was a very effective protocol, but it was very difficult to administer in hospital because it required 3-hour dosing. In addition to that, it was not a very practical outpatient protocol. So what we decided to do is to ask Anil Maharaj to computer model what it would look like to achieve the same serum levels at the same rate using a transdermal delivery method. And so he modeled these lines. And through this process, we were able to come up with a brand new way of treating our patients with buprenorphine, this very effective medication, but having it delivered through the skin instead of taking it by mouth. So it's a patch you put on the skin, and therefore you don't have to dose it every 3 hours. So suddenly now we have this amazing protocol that we can use in an outpatient setting. The pharmacokinetics are almost identical, and it's just as efficacious, but it's much more effective. And now we've expanded this protocol. What I have here is a 48-hour protocol. We've now developed a 24-hour protocol, but using the same process. So the concept I'm trying to highlight here is this translational research, applied pharmacology, coming up with a clinical problem to treat our patients, reaching out to our basic science colleagues for solutions, and then applying the solutions. This was so effective that it was incorporated into the California Bridge guidelines. So these are guidelines that were initially used to distribute clinical guidelines in California for treating patients with opioid use disorder. And now they've been distributed across North America, more than 300 hospitals. So you can see that they have our protocol here, and they also have incorporated our graph into their guidelines. So, this is an interesting story because we had a clinical problem. We solved it with our basic science colleagues, and now this protocol is now being used in hundreds of hospitals across North America. So another clinical problem that we encounter in treating patients with opioid use disorder is the time it takes to titrate somebody onto a medication like methadone, opioid agonist therapy. Now, the fundamental problem here is the fact that we don't know what a patient's opioid tolerance is. So I'll just break it down sort of in simple terms, in that when a patient uses opioids, they become tolerant to the opioids. Now, the treatment for opioid addiction is to replace illicit, dangerous opioids like fentanyl with pharmaceutical-grade, long-acting opioids such as methadone, which don't cause intoxication, can reduce cravings and withdrawal, and can block the illicit opioids. It's evidence-based, proven medication that works very well. However, the problem with methadone and the current opioid agonist therapy regimens is that because we don't know how tolerant our patients are, in other words, the clinical problem is we don't have an objective measure of opioid tolerance, we don't know how much to give them. We don't know how much methadone will match a patient's requirements. So therefore, we have to start at very small doses and gradually build up the dose to avoid overdosing them with our medications. And this can take weeks to months. So here, this just, you can see that current guidelines, starting doses of methadone is about 30 to 40 milligrams. And we know with fentanyl use, patients require well over 200 milligrams of methadone. And it can take weeks to months to get from 30 milligrams to 240 milligrams, for example. Right? And this speaks to that statistic I pointed out earlier today, which is that after about a year, only 16% of patients who were started on methadone remain on methadone. And the reason is most patients will never get to an adequate dose that will meet their opioid requirements, reduce cravings and withdrawal. This was much easier during the heroin age. 100 milligrams, 50 milligrams of methadone was sometimes adequate. That's not the case anymore. So the fundamental problem is we don't have an objective measure of opioid tolerance. We went to solve this, and we're currently doing a clinical trial at Hope to Health, which is a clinic in Vancouver's downtown east side. And our initial solution to this problem is kind of interesting. We decided, ironically, to use fentanyl as an objective measure of opioid tolerance. So here's how this trial works. A patient comes in who's addicted to fentanyl, has just used fentanyl and is not in withdrawal, they're likely in withdrawal. They come into our clinic, we need to measure what their opioid tolerance is. So we give them intravenous fentanyl through a pharmacokinetically derived protocol that we've had our health pharma colleagues at the Department of Pharmaceutical Sciences to develop. So they come in, they get IV fentanyl until they're comfortable, and we have objective measures to determine when a patient has had enough. And then based on the total amount of fentanyl that was required to get a patient out of withdrawal, we calculate a starting dose of methadone, and we give the entire dose on day one. So here you can see graphically, a patient will come in, and we will measure their opioid tolerance based on how much fentanyl was required, and then we'll give them an equivalent dose of methadone or sustained release oral morphine, which is long-acting morphine, which is the other treatment for opioid use disorder. So now, instead of it taking weeks to months to get to a dose of 200 of methadone, we're doing it on day one. You can imagine how dramatically this is going to change the management of opioid use disorder. And while we're doing this, we are also doing a PK sub-study. We're measuring blood levels of fentanyl and methadone and morphine to get a better understanding of what actually is happening in these types of protocols. So we're generating the evidence, and we're trying to fill the void of evidence that currently exists in the age of fentanyl use. Okay. But clearly, most clinics are not going to be able to give a patient IV fentanyl. That's pretty drastic. So we need another measure of opioid tolerance. And the solution was to reach out to our colleagues in the Department of Chemistry and to see if we can come up with an instrument that very quickly, accurately, and inexpensively can quantify opioids. And this is the device that we've come up with. So this is a collaboration with Professor Dan Bizzotto, Professor Glenn Samis, and it's an electrochemical device. It's unique technology that allows us to measure opioids, not only as a yes or no answer, but actually quantify the amount of opioids within a sample. And the goal is to ultimately replace fentanyl from our protocol with this device. So a patient comes in, we measure their opioid load, we use that information to calculate an adequate starting dose of methadone. So a point of care opioid quantification device that objectively measures opioid tolerance. Another really interesting example of translational research where we're using, again, we're starting with a clinical problem, reaching out to our basic science colleagues and coming up with a solution. Okay, so one other example of this, and I'm not trying to belabor the point, but I think it's interesting. Another example of translational research, our lab, is, again, solving the problem that we don't have a way of distinguishing ethical versus illicit supply of opioids in the supply chain. So the clinical problem was, me as a physician, if I prescribe a pain patient hydromorphone, I don't now have a way of knowing if that patient is taking the medication that I've prescribed, if they're taking the amount that I've prescribed, or if they're diverting what I've prescribed, or if a patient comes into hospital with an overdose, we don't have a way of understanding what they've used necessarily or where they got that medication from. If I prescribe a patient fentanyl for chronic pain and they get opioid toxic, and I suspect addiction, I don't currently have a way of distinguishing whether they in fact got opioid toxic from the fentanyl that I prescribed or if they used illicit fentanyl on top. So this was a clinical problem. We went to our basic science colleagues, and the solution was a way of molecularly labeling opioids in a very interesting way that allows us to essentially create a molecular license plate for opioids. Think of it as an automotive VIN for each opioid. So when this opioid is prescribed, now we have a way of molecularly tracking where it originated from. So if a child overdoses on hydromorphone, we would potentially have a way of delineating where that hydromorphone originated from. So this was a way of solving this clinical problem that we had, but then it struck us, well, we could also do this with illicit fentanyl potentially. Now we know that fentanyl is extremely easy to synthesize if you have precursors, but it's extremely difficult to synthesize if you don't have precursors. So if we have a way of labeling fentanyl precursors, we can now track where these precursors originated from. And we can potentially hold manufacturers accountable for selling precursors to unscrupulous labs. Okay, now we're going to move on to some a little bit more fun, interesting research programs that we have. And one is using digital technologies, and this is using mixed reality devices. So the thought is, can we use non-pharmacological measures to treat pain and addiction, as well as maybe mental health and other factors? So we're using mixed reality in patients who are admitted to hospital in acute pain and or withdrawal. So we actually have a patient right now who's admitted to hospital. She just had a spinal cord injury. She's had a spinal cord surgery, extremely anxious, new disability, lots of pain, requiring tremendous amount of hydromorphone. And we anticipate that there's likely a pain anxiety cycle contributing to this patient's opioid requirements. Now, you can imagine with this device, we can completely transform a patient's environment from sitting in the hospital bed, not being able to move, to wherever she wants to be. And we can incorporate mindfulness exercises within that experience. And this dramatically can reduce a patient's level of anxiety, which then the hope is will then translate into reduced pain scores, as well as reduced opioid requirements in hospital. You can imagine a patient who's stuck in the ICU, intubated, can't move. There's lights, noise, chaos all around them. That environment can be completely transformed with a device like this. So we're getting towards the end of the presentation, but I did want to talk about our digital, a little bit more about our digital technologies. And this is, one of the clinical problems, again, was now that a patient is on treatment, how do we retain them onto treatment? So we thought about, okay, is there a way we can develop a digital tool that can help patients stay on treatment? Now, we know that there are plenty of digital algorithms that currently exist that are designed to induce dopamine release and get patients essentially addicted to a device. And we're talking about gambling algorithms and video game algorithms. So the thought was, can we actually use these algorithms to reinforce positive behavioral change that's associated with retention onto treatment? So we teamed up with BCIT, the School of Computing and Academic Studies, and we have developed an app. We actually have a working app that we're going to start testing very soon. We've recently received ethics approval to evaluate this app. But again, another example, clinical problem, reaching out now to our digital colleagues, Department or British Columbia Institute of Technology to come up with a solution. I did want to talk about our clinical recommendations and guidelines that we're developing through our program. And this is now using our collective clinical understanding, as well as our understanding of the literature and science to come up with guidelines to treat our patients. I think what we've seen in addiction medicine so far is a void of evidence. And sometimes things are done because they may sound like it's a good idea, but not necessarily because they're backed by evidence. And I think it's important to have an evidence-based approach to treating our patients. So our goal with developing guidelines is to, let's go back to the literature, let's re-examine the evidence, and let's make sure that what we're doing is actually in keeping with the evidence that currently exists. And when we're lacking evidence, okay, now that's our responsibility to generate the evidence that's required. Okay, we're almost at the end. And now we're at the primary prevention part of our research. So at a certain point, it struck us again that much of our research is focused on patients who already have an addiction. But what about preventing addiction from happening in the first place? So we looked at what's been generally done in terms of primary prevention. And it turns out that much of it has been very ineffective. And we're talking about, expensive, moralistic, fear-mongering campaigns such as Just Say No or This Is Your Brain on Drugs. And for us who have some understanding of addiction, can appreciate that addiction is much more complex than, for example, if a patient or if an individual, young person is at a party, they're feeling insecure, they don't fit in, the drugs are being passed around, it's their turn to try it. They're not going to think to themselves, oh, Nancy Reagan said, just say no, so I'm not going to use the drug, right? I think it's much more complex than that. So then the question was, what can be effective or what is effective in managing young people's habits and behavior? So what we came up with, the answer is obvious, and that's social media. So we know that social media has huge influence in terms of altering people's behavior, particularly young people. And much of that is through the power of social media influencers. So the thought was, can we harness this power of influencers to bring about positive behavioral change when it comes to mental health and addiction? So we've developed a campaign. And we're doing this campaign in conjunction with professional skateboarders. And we're using skateboard culture as a test case for this type of approach. So the concept there was, let's start small within a particular subculture to try this type of approach, and then we can expand it to a larger subculture. So the campaign is called Natural Stance. We're actually very close to launching it. Probably within the next 6 weeks, we're going to launch it. And the thing is, we're going to evaluate this scientifically, pre-post exposure surveys to see if it actually has an effect. Maybe it won't, but if it does, this could be an interesting approach that can be then expanded to other subcultures. Here you can see Chris Haslam, who is a world-renowned professional skateboarder who's teamed up with us. And we have a little podcast that we're launching soon that's associated with this campaign. So it's actually a lot of fun. I'm going to close with we're going to briefly talk about our education. So we have 2 fellowships that's associated with our lab. We have a physician fellowship and a nursing fellowship. And I think this speaks to the importance of, regardless how much evidence you generate, if you can't get these new clinical protocols and approaches into the hands of the next generation of physicians and clinician researchers and nurses, we're not doing our job in terms of translational research. We're just doing research. So our fellowship is the only fellowship that we're aware of worldwide that combines mental health, pain, and addiction, all within one program. And our clinicians and nurses graduate with the ability to treat this complex interplay between mental health, pain, and addiction. And I think it's important for us to have the voice of people with lived experience. So we've developed a patient and community advisory board that's led by individuals with lived experience to ensure that, we sometimes as clinicians think we have the answer, we're doing what's important to our patients, but it's really important to have the input of our patients as well in our work. Okay, So I have a brief video that just describes the account of a patient that we have treated with one of our buprenorphine protocols. And this is interesting because this patient, well, you'll hear it from them, directly from them. So can you tell me, you use fentanyl, or you did?
Yeah.
How long were you using for?
20 years.
20 years. How much fentanyl were you using in a day?
Anywhere between 3 and 5 grams.
3 or 5 grams. Okay. And you're pretty high tolerance, huh?
Yeah.
Gotcha.
Yeah.
And what was your living situation?
I had a place of my own until a month ago.
And then, as of a month ago?
I've been staying with a friend.
So sort of couch surfing type?
Yeah.
Okay. Now, you were admitted to the hospital last week, and we did a rapid low-dose induction onto buprenorphine.
Yeah.
And then you ended up, I think in 48 hours, you got the sublocade shot.
Yes.
The long-acting buprenorphine extended release shot.
Yeah.
How did things go after that?
Pretty good so far.
Yeah. Any cravings or withdrawal?
Not really.
And you told me you tried to use one time.
One time when I first got out,
And what happened?
I couldn't get high. It was really frustrating.
So have you used since?
No.
Sounds like it's a success for you, huh?
Yeah, so far.
It's pretty exciting.
Yeah.
So what's the plan now? So what's the plan now?
I'd like to do a program.
Yeah.
Yeah.
20 years of use, huh?
Yeah.
Pretty exciting.
Yeah.
Good work, dude.
No, sir.
All right. Okay, thanks for this.
Yeah, no problem.
I think it's pretty powerful, right? This is somebody who was using for 20 years and using high doses of fentanyl. And within a very 24 hours in hospital, we were able to get him onto depot preparation buprenorphine. That's eliminated his need to use fentanyl. Out of habit, he used one time after he went home. He didn't get high. He's like, okay, I'm done. It's a pretty dramatic change in this person's circumstance. And this is just a result of the translational research that we're trying to do in our lab. So that's the end of our research, of our presentation, but I did want to highlight some of the people in our lab. You know, none of this would have been possible without sort of the hardworking people that we have in our lab. And yeah, so all of my thanks goes to them. Thank you, guys.
Thank you. Excuse me. Thank you for that excellent and really inspiring presentation. We'll take 5 minutes for questions.
Hi, thank you so much for such a clinically relevant talk. I'm curious too, because polysubstance use is so common, like, are you finding differences in efficacy and response when there are other drugs in their system? Or have you looked at that at all?
So, yeah, so polypharmacy in turn, you can think of it in two ways, or polysubstance use. One is the different types of substances somebody uses, but there's also now we're finding polysubstance in terms of opioids. So we can have patients who can come into hospital and they will have used fentanyl, but they will have used other fentanyl analogs and nitazines and new novel agents that we hadn't seen before. But almost all of them will have also been exposed to high doses of benzodiazepines. And because fentanyl is so sedating and you add benzodiazepines to it, it's even more sedating, many of them will use methamphetamine or some type of stimulant to stay more awake to be able to use opioids. So polypharmacy is actually, polysubstance use is actually the norm right now. It's almost the rule, not the exception. And it does make things much more complicated because now you have overlapping toxidromes. You have the toxidrome related to benzodiazepine withdrawal as well as opioid withdrawal. And agents that we use for benzodiazepine withdrawal can complicate opioids that we use for opioid withdrawal. So it does become an interesting and complicated clinical scenario. We also encounter clinical scenarios that we have never seen before. Unusual catatonias and deliriums that nobody really knows how to manage. And I think that speaks to a lot more research that we have to do, particularly when it comes to characterizing the substances that are being used and to correlate those substances with the clinical outcomes and toxidromes that we're seeing. So yeah, that's a good question. Mm-hmm. Yes.
Yeah, thanks for a really lovely talk. I had two quick questions. So one, I was wondering about kind of patches and like individual safety and kind of public safety from a perspective. So I've had some patients come in and say they were targeted because of the medications they were prescribed. And so I'm wondering if this increases liability to patients who have maybe like a transcutaneous kind of delivery system to violence. Has that come up from a psychosocial perspective? Does that affect their access to care? And then in terms of like if maybe patches are inappropriately like dispensed perhaps, or like taken off of someone, how like are there any kind of considerations to prevent perhaps like opioid naive individuals kind of being exposed to it? And the second question was kind of more about the app, which was really interesting as well. I was wondering how implementing an app utilizing kind of reward pathways in individuals who may have liabilities in that pathway to begin with might work.
Both very good questions. So the first question was really the concern around diversion of buprenorphine patches that we use for our protocols. So buprenorphine in of itself does not have much of a street value at all in British Columbia. In some countries it does. British Columbia, it doesn't. So we don't often see buprenorphine diverted. Most medications that are diverted and have some kind of a street value are when it comes to opioids, they're the ones that have sudden onset, sudden offset, because they're the most rewarding. You can imagine if you want to get high, you don't want to wait 12 hours for the effect to take place, right? The patches, they're very slow onset, very slow offset, and they're very low doses. I can slap a couple patches on you and you probably won't feel it. And the other thing with buprenorphine is that it has a ceiling effect with regards to respiratory depression, meaning that it's difficult to overdose with buprenorphine. Not impossible, but it's extremely safe. And it's because of that that we freely give carries of buprenorphine to patients who use opioids. So diversion of buprenorphine is not something that I am too concerned with. Diversion of buprenorphine patches is something that I don't even think about. Very good question though, because it does happen with fentanyl patches, which is a different molecule, different delivery, etc. The second question was potential negative consequences of utilizing an app that uses a reward pathway.
Or just like even if they have like an attenuated response because of liabilities in their existing pathway, like is it as effective, but also like, yeah, could there be negative effects?
Oh, is it as effective because liabilities? I don't know. It's a good question. And this is something that we need to study. So I don't have that answer for you.
Thanks.
Yeah, absolutely. Now, in terms of potential negative outcomes, the one argument is that, well, will you now get this individual addicted to using your app, right? Fair enough. That's a good question. So there's a couple of things. One is we're developing tapering algorithm to make their reinforcement less and less effective, to be able to taper people off of the app. And the other is, if we're talking about patients who've had overdoses on fentanyl, right, who have severe opioid use disorder, and if this app helps them to remain on treatment and off of fentanyl, okay, so maybe they might be on some level hooked onto the app, but when I think of the pros and cons, if it's helping prevent them from using fentanyl, maybe they're better off. Yeah.
So this is sorry, I just have time for one more question. So, yeah. Okay. This is probably a naive question. So moving off from addictive, and if it is, how do you help people get over that?
Yeah, it's a good question. It's not a naive question. It's an opioid. It's a semi-synthetic opioid. It's a very good question. I was recently at a conference in France, and there was a presentation by a group from Finland. And buprenorphine is the #1 drug of abuse in Finland. Who would have thought, right? And it's because they don't have fentanyl, they don't have heroin, they have very high restrictions in prescription opioids. And when they did have a heroin problem, they prescribed buprenorphine quite freely, and now they have a buprenorphine problem, illicit buprenorphine problem. So it is addictive in that sense. much safer than fentanyl. And when prescribed properly and used properly, you don't experience the intoxication reinforcing effects that you would with illicit opioids. So when we treat patients with opioid agonist therapy, the goal is, number one, we want to replace dangerous illicit opioids with safe, long-acting prescription opioids that will not cause intoxication and will prevent overdose. Over the longer term, once we've now incorporated psychosocial interventions, maybe address some of the underlying driving factors behind the addiction, including underlying mental illness, social factors, etc., and there's been a change in that individual circumstance, then we can try to slowly taper off the buprenorphine and have them off of opioids altogether. The evidence is that there's an extremely high risk of relapse when you taper opioid agonist therapy. And I don't like to do it unless I've incorporated those psychosocial interventions. Very good question, though.
So unfortunately, again,
No,
I
we're
know
out of
that there are probably many more questions, but we will have to end just for the sake of time. But again, thank you, Dr. Azar, for sharing your group's work. It's been fantastic having you.
Thank you. My pleasure.
So now we'll go into the presentation of awards. So, so the first award we're presenting is the 2025 Nissia Laura May Elvin Memorial Prize in Schizophrenia Research. This is awarded to a trainee based on a research paper that they have published in the field of schizophrenia in the past year. This year, the award goes to Mr. Hong Liu. So Mr. Hong is a medical student who completed his research project under the supervision of Dr. Anne-Marie Craig. And his paper was published in Molecular Psychiatry titled Targeted Splicing Approach for Alleviation of a Neurorexin-1 Haploinsufficiency Model. So if Hong is here, if you want to come down, I think we want to take a picture with your plaque. Thanks. Okay, the next award is for the 2025 George Davidson Award for Scholarly Activity. And this is going to Dr. Jenny Zhang, who is a PGY3 in the Fraser track. Next award is the 2025 Significant Contribution to Research and Residency. And this is going to PGY3, who we heard from this morning, Dr. Tara Gartner. Okay, so now we're going on to our awards, which are based on presentations and posters from today. So the first is going to be our award for the most popular Lightning talk from the morning session. And that is going to be presented to Naomi Fute, who presented on her work in cognitive clustering. Our next award is for favorite lightning talks from the afternoon session. And this was actually a tie. So this is going to be awarded to Austin Lamb and Andrea Koo. And then our last set of awards, the first of the last set is the Zeldovich Poster Award in Basic Science and Translational Research. And this goes to Hengame Marsbani. And the last is the Zeldovich Poster Award for Clinical Research, and that goes to Ruki Agbo Havbi. Apologies if I said that wrong. All right, so I believe that concludes our research day. Thank you again so much for attending, and a special thanks to all of our presenters. I think we really highlighted the impressive range of work that our department is doing. So please do join us for the meet and greet. It'll just be outside in the atrium. We'll have pizza, and you can have a chance to speak with and meet some of our faculty.